Okay, being noon 05 or 6:05 for me, we should get started. My name is Andrea Margulis. I am the current chair of the Education Committee, and it's in that role that I am presenting this great set of speakers that we have lined up for the Advanced Methods course this year. This is the title of the course. We'll be discussing about pharmacoepi methods used in COVID-19 research at this stage of the pandemic. We will first hear the talk from Rohini Mathur. That talk will take approximately 30 minutes. Then we'll have a short Q&A specifically on her talk. We'll use 5 minutes for that, and then we'll have a short break. Then we'll have David Carroll give a talk, another 30 minutes, 5 minutes of Q&A, and then a bit of a longer break. Then we'll hear Sarah Tartov for 30 minutes, short Q&A and short break, and then we'll finish with Diego's presentation. I cannot pronounce the surname. We'll have a short Q&A, and then we'll reunite for a general Q&A. And for the general Q&A, in addition to the 4 speakers, we'll have an additional panelist, Christopher Wrench. Christopher will be able to provide an additional perspective on the topic of the first talk, but a somewhat different perspective. So we'll get there. And this is the end of the introduction. And we can get started with Rohini. I will stop sharing screen here.
How does that look to everybody?
Looking good.
Great. Well, thank you so much for inviting me today. My name is Rohini Mathur, and I'm an epidemiologist at the London School of Hygiene Tropical Medicine. And I'm going to be speaking to you a bit today about conducting research using ethnicity data in routine health records and some applications to COVID-19. This project was funded from a range of sources over a number of years, including the ESRC, the Wellcome Trust, and the MRC. I don't have any other personal or financial relationships to declare. So the outline of this talk is in 3 broad sections. I'm firstly going to discuss a bit about the history and context of ethnicity in the UK and some brief comparisons to other countries. I'm going to talk a bit about the coding and completeness of ethnicity data in UK health records, and finally discuss some important considerations for methodology for using ethnicity data in conducting pharmacoepidemiology and COVID-19 related research. So it's probably first easiest to define ethnicity by what it's not, and specifically in the UK context, we use the term ethnicity instead of race. And historically, these terms were used synonymously, but race means really that the belief that humankind is made up of biologically distinct subgroups. And developed in the 19th century, theories about race were used as a means to justify imperialism, eugenics, and slavery. However, the notion of race as a genetically immutable trait has been widely discredited. In fact, many studies have shown there's no genetic basis to commonly use broad ethnic and racial categories, though this doesn't preclude the existence of some pertinent genetic variation which can influence health. Ethnicity is more typically thought of as a social construct which identifies an individual's self-identification, which encompasses a broad range of characteristics, some of which are outlined here. And the fact that these factors can manifest unequally in different population groups can be conceptualized as ethnic differences, and these are relevant to the context of geography, politics, and time. And the UK is somewhat unique in Europe. It is the only European country which actively promotes the collection of ethnicity data in the census and across all government bodies. And in fact, the collection of these data in other countries such as France is considered illegal. So UK data sources are somewhat uniquely placed in the European context to study the association between ethnicity and a range of health outcomes. So there is no one universally accepted definition of ethnicity. As mentioned before, the meaning and interpretation is context dependent, and it is fluid over time and location. However, for analytic purposes, we have to operationalize ethnicity into somewhat practical categories with the understanding that these encompass a rich variety of concepts. And the categories we use are not natural in any way. They just reflect groupings that are relevant at that particular time. And the census is a good example of this. So as you can see, census categories have grown and changed over time. These pictures here are from the census for England from 1991 onwards, when ethnicity was first introduced as a question. And we can see that more categories were added to the standard classifications, reflecting both the numerical growth in the representation of certain groups and a more nuanced understanding of meaningful categories. And this process is particularly important, such as countries in the UK and the USA, where changes in migration patterns have increased the ethnic diversity of the countries and created new ethnic categories and groups for later generations who may have multiple and novel ethnic identities of themselves. Similarly, the ethnicity coding hierarchies in the USA are also diverse. And an important point to mention is that the terms race and ethnicity are both used in the US with some slightly different meaning in their terminology. And in fact, the US definition of race is very similar to the UK definition of ethnicity, which is a socially defined construct not related to biology or genetics. However, there's also a separate ethnicity category, which we do not have in the UK. And while this is very well suited to the US population, it can make comparisons between and across countries difficult. So related to that, there are some key challenges to measuring and using ethnicity in research. For epidemiology and the work that we do, the categories must be meaningful and discrete in order to be interpretable. However, because the meaning of each category is context specific, it's difficult to make comparisons. For example, the ethnic group Asian has a very different meaning in the UK, where it typically refers to South Asian communities compared to North America. And as we mentioned, the types of categories are continually evolving, making changes over time, perhaps difficult to compare, but important to recognize. And furthermore, the categories that we use inevitably hide underlying heterogeneity, and the high scale categories may not actually reflect the nuanced differences between the many different types of people and cultures that contribute to the categories. However, as long as we recognize the limits of these categories and approach their use critically, they can provide a very useful tool for conducting epidemiology research. So I'm going to talk a bit about now how ethnicity is recorded in UK primary and secondary care data. So the standard ethnic categorization across the UK NHS is that of the 2001 census, which has 5 high-level categories and 16 or so subcategories shown here. Usefully, in primary care settings, there are hundreds of clinical codes which map to these census categories. There are over 300 read codes, which is the standard clinical terminology in UK primary care, and over 650 SNOMED codes, which are increasingly being used worldwide. So this gives us great opportunity to look at ethnic differences both in the high-level categories listed on this slide, but also between any other types of subgroups that we're interested in. This type of high-level research is, however, more difficult using secondary care data, which only records ethnicity in the 16 categories and therefore doesn't allow any sort of more granular exploration. One further problem with the ethnic categorization in the NHS is, of course, the use of the 2001 census. We've since had 2 censuses since then, where the categories have changed slightly, as I showed, and this makes it difficult to compare across different studies, which use slightly different definitions of the census categories. But of course, using the source data, these can be recategorized how you wish. So ethnicity recording was first introduced in UK primary care in 1991 to coincide with the computerization of healthcare records. It was introduced into hospital episode statistics in England in 1995. Ethnicity recording remained low, as you can see, during the first decade or so of its introduction. However, the recording of ethnicity was incentivized under the Quality and Outcomes Framework. And this is a scheme to improve chronic disease management and data quality. And we can see from the graph that the recording of ethnicity improved drastically in primary care after the incentivization. However, this was removed in 2011, where the completeness has tapered off. Current estimates, however, of primary care ethnicity recording do show completeness of around 80%. So we have maintained some of the completeness that came from the incentivization. Turning now to how to best use these data, I'm going to talk about a pragmatic method that we have developed in our research group for assigning ethnicity. So firstly, just a brief description of the consistency of ethnicity recording in the UK Clinical Practice Research Data Link, which is one of the health databases we use. So people can have ethnicity recorded over multiple visits, and they can have multiple records of ethnicity on their clinical care record. And so starting with the population with valid ethnicity in the CPRD, we found that over 85% only had one ethnicity code on their record, and that just 14.6% had more than one ethnicity on their record. So the vast majority only have one ethnicity, which makes it straightforward to use. Amongst those with multiple ethnicities, we found that 79% had multiple ethnicities which fall into the same 16 categories. 13% had ethnicities which fell into the same high-level group, and 8% had multiple ethnicities which spanned different groups. So I'll just illustrate these with some examples. So in scenario one, where multiple ethnicities are the same, we can see this is the record for a single individual who's had their ethnicity recorded 4 times, each with the exact same clinical read code 9S1. In scenario two, we have a person who's had their ethnicity recorded using several different unique read codes. However, these all fall into the same higher level category of South Asian. So you can see this person has been recorded as being Bangladeshi, other Asian, Indian, Tamil. And so these multiple instances of different recording may occur when a person perhaps enters different information on the form. They may actually change their ethnic identity over time or feel that they want to identify differently, or it may be coding error on the part of the people entering the data. In the third scenario, we have one individual whose multiple ethnicities are categorically different. So we can see a wide spread of ethnic groups here, ranging from white to South Asian and to Black. And so it is difficult to say what's happened here, but likely, again, this is some sort of coding error or some sort of poor linkage between records. So how do we deal with these multiple ethnicities? We've developed a fairly simple algorithm to look at identifying codes for ethnicity in primary and secondary care resources, and then determining which one should be the single best ethnicity. So using the primary care record as the gold standard, we can use the most frequently recorded primary care code if available, and if not, the latest. And if these are not available, to use the same in the hospital data. So this way we can assign an individual with our best guess ethnicity. So now I'm going to talk through some considerations of how best to use routinely recorded ethnicity data in research with an example from COVID-19. I'm going to illustrate 5 key considerations: the social context, biases in data capture, ways of categorizing ethnicity codes, conceptualizing ethnicity epidemiologically, and methods for dealing with missing ethnicity. So as touched on briefly before, ethnic classifications used in standard census and government categories reflect how particular ethnic groups have been racialized. That means how their ethnic identity has been shaped by historical and political forces. And understanding how ethnic group categories have come to be is really important for understanding health differences between ethnic groups. as we need to understand the political and historical context which have shaped the wider determinants of health. So ethnic differences in health are very strongly related to differences in education, housing, occupation, and experiences of racism and discrimination, including structural, institutional, and interpersonal racism. Secondly, we want to think carefully about biases in the capture of ethnicity data. So what causes ethnicity to appear on the primary care record? And we need to consider that the recording of ethnicity itself is a marker of engagement with the healthcare system. And people who don't have their ethnicity recorded may be systematically different from people who do. So there may be differences in who attends primary care, who is asked about their ethnicity, whether a person feels that they can answer the question, whether they feel represented by the categories, and whether there is an incentive to actually capture ethnicity in the healthcare consultation. So people who are less likely to attend health services may also be less likely to have their ethnicity recorded. They may be younger or healthier, so they may have fewer reasons to visit the healthcare setting, or they may perhaps be university or college students who are transient and are not necessarily registered with a GP for some period of time. They may be people who are homeless or asylum seekers who again may not have a stable address or access to the healthcare system. But there also may be people who are less likely to be asked about their ethnicity. You know, the GP may feel that they don't need to ask someone about their ethnicity in a certain context if it's not related to, say, a chronic condition, or it's not part of an annual assessment. They may not be asked, but also if they are asked, they may also say, I don't want to give you that information. So there's all sorts of reasons why ethnicity may be incomplete. The third thing I wanted to talk about is the categorization of ethnicity codes. So of course, the standard categories are very useful for making comparisons across different studies which use the same methodology. However, these may not always be appropriate for your specific research question. As an example, there's a study conducted by my team some time ago looking at MMR vaccination rates. And in particular, there was concern around lower rates of vaccination in the Somali community. So we used the standard ethnic categories for the other ethnic groups, but pulled out the Somali group themselves. And we found that actually MMR vaccine uptake was about half that in the other ethnic groups. And if we hadn't thought to look at this separately, we would never have uncovered this big disparity. Another problem with the standard categorization of ethnicity codes is, as I mentioned, people who don't feel represented by the categories given and may not respond or may classify themselves as other. And in fact, the other is a terribly unuseful category for healthcare research, as it's very heterogeneous, it's a bit of a catch-all and actually really difficult to interpret. And as the population diversity grows and changes over time, particularly between censuses, we find that more and more people are using the other ethnic category, which is not terribly helpful for planning and healthcare resource allocation. So bespoke categories may be required for your specific study of interest, and it's important to consult with the communities whom you are studying and also healthcare providers to understand better about how and when they code ethnicity. I'm now going to speak through the final considerations using an example study for COVID-19. So this was a study conducted by a team jointly across LSHTM and Oxford using the Open Safely data platform. And this was to look at ethnic differences in SARS-CoV-2 infection and COVID-19 related outcomes among 17 million adults in England. And the aim of this study was to identify ethnic differences in these 5 outcomes listed here across the first 2 waves of the pandemic, firstly between February and August 2020, and secondly between September and December 2020. And so I wanted to use the study to give an example about how to conceptualize ethnicity in epidemiological models. And as mentioned, ethnicity is a proxy for a number of other interacting factors. And so we wanted to think carefully about what ethnicity is a proxy for in the data that we have. And so we wanted to show the links between ethnicity, but also with ancestry, racism, culture and community, education, and occupation, which are then kind of more directly linked to exposure to SARS-CoV-2, and also other things such as genetic and biological factors, risk and other comorbidities, and access to healthcare. So really, when we see ethnicity as a variable in our data set, we need to think about all these other concepts that it may represent. So with our conceptual model in mind, we started our study of 17 million people and found that 63% of our study population were of white ethnicity, 6% were South Asian, 2% Black, 1% mixed, 1.9% other, and 26.3% unknown, which is a large proportion, but not unusual across the UK. So we had a number of people with known ethnicity, but a large proportion of unknown ethnicity that we wanted to explore further. So the first question we had are people of unknown ethnicity different? And so this is just an example of some baseline characteristics across the known ethnic groups and the unknown ethnic groups. And we found that people with unknown ethnicity were most similar to the white group with respect to deprivation, household size, and type 2 diabetes. And you can see already in this graph here that each of these things is highest in our South Asian and Black minority groups, particularly living in a large household, which was very high for South Asian groups. And I'm just going to illustrate some of the findings related to COVID-19 mortality. So this is quite a busy graph, and the categories on the left here are the high-level 5 categories in bold: white, South Asian, Black, mixed, and other, with all of the constituent 16 categories below. And this was important as it allowed us to look at high-level trends, but also between group differences. And looking at COVID-19 mortality in wave 1 to wave 2, we found important differences for South Asian groups compared to white. So in the first wave, we found that risks of mortality were raised for the South Asian group, and that was driven primarily by the Indian and other South Asian groups, but was comparable for the Pakistani and Bangladeshi groups. However, in wave 2, we saw a stark increase in all South Asian ethnic groups compared to the white group. So for South Asian groups, we saw that the disparities widened over time. However, in contrast, we saw that disparities were attenuated for Black and other minority ethnic groups. So here we've got the same graph with the Black group highlighted. And we can see that in wave 1, all Black ethnic groups were at consistently higher risk of COVID-19 mortality, but that in the second wave, the excess risks were reduced entirely so that no differences between Black and white groups remained. So in a UK context, we found this widening for South Asian groups and an attenuation for Black and other minority ethnic groups. How does this compare with studies conducted in other parts of the world? So this is a comparable study conducted by a team from the Veterans Affairs Group looking at COVID-19 infection over time. And we can see here that the patterns are very similar to those of the Black and other minority ethnic groups, which is that the disparities were widest in wave 1 and then attenuated over time to the point of no difference and slightly reduced risk across the wave 3B, which corresponds with our wave 2 in our original study. So we can see here that there are patterns of ethnic inequalities mirrored across different settings. And so it may be that there are some common drivers of ethnic inequalities in COVID-19 across the UK and the USA. And Christopher, who's here with us today, is one of the authors of the study and would be happy to take any questions you have about this in our question and answer period. So turning back to our difference in patterning of ethnic outcomes, the question arising from our UK study was why disparities increase for South Asian groups but decrease for the other ethnic groups. And our observational study prompted the conduct of a qualitative study which gave further insights into waves 1 and waves 2. And it found that the poorer outcomes in South Asian groups may have been primarily due to the Pakistani and Bangladeshi groups and the interaction of health inequalities, other social disadvantages, barriers to healthcare access, and the COVID-19 policies and practices. And the reason I wanted to bring this up is that observational data alone cannot give us the whole story of ethnic differences. The coded data we have are a kind of superficial descriptor of many, many important things going on under the surface. And so the combination of both qualitative and quantitative work is essential to really uncovering and tackling health disparities. So the final methodological point I wanted to talk about is the use of multiple imputation for unknown ethnicity. So it may be possible that the ethnicity data in our routine data sets is not missing at random. As I mentioned, people who have ethnicity recorded may be systematically different from people who don't have ethnicity recorded. And this may have an important effect on the exposure outcome relationship that you're interested in. So we applied multiple imputation for unknown ethnicity to our COVID-19 study in England. And we found reassuringly that in this case, the results of the multiple imputation mirrored those from the complete case analysis. And thus we were confident that there was no important bias introduced by limiting the study to those with recorded ethnicity. And so while this was confirmatory for our study, of course, this may be different depending on your particular study question. So overall, for our COVID-19 study, we found clinically important ethnic differences in the risk of COVID-19 infection outcomes in what was at the time the largest European study to date. We found there was great value in disaggregating ethnicity into the detailed 16 categories, which revealed important within-group heterogeneity. We found that people of unknown ethnicity were most similar to the white group in terms of baseline characteristics. And the multiple imputation showed that people who had missing ethnicity did not have a meaningfully different risk of COVID-19 than people with known ethnicity, and that our data were not necessarily biased with these missing categories. So in conclusion, ethic monitoring is essential to uncover inequalities and patterns of disadvantage, which may otherwise remain insidious. And ethnicity is a useful lens through which to identify population groups between whom disparities might exist. And it's important to be clear throughout that health outcomes are determined by a complex interaction of factors, not all of which may necessarily be observable in health data sets. So thank you very much for your time. Both Christopher and I are happy to take any questions you may have after this session. Thank you.
Thank you for this wonderful presentation. And thank you, Christopher, too, for joining at this time to bring closer the US perspective on this. I was wondering whether anyone in the audience has any question.
There is a question from the audience. It says, is there a correlation between the HR estimate during wave 2 and the outbreak in India that happened a few months ago?
That's a really good question. And I think that is quite possible. And I think actually one of the cited factors for wave 2 coming to the UK was the delay in closing borders, particularly with India. So I think that is one of the contributing factors, is this cross-pollination of infection between the two countries.
There's a second question that goes along with it as well, and says, how does the data collection overlap with the changes in travel restriction? Movement of population could potentially explain why the HR distribution changes within this.
Yeah, absolutely. So I think that is this is one of the biases, I suppose, that we need to think about in healthcare data, is that the data that we had to look at the ethnic inequalities required the person to go to the GP. So if there were any kind of influxes and outfluxes of population over the past year, we wouldn't necessarily have captured them in routine electronic healthcare records, because people who are residents of the UK may not have, deregistered with the GP, they may not have been aware of their travel, and people entering the UK wouldn't have appeared at all. So yeah, the data that we had for the study is probably not strongly related to the travel influx and outflux over the time of the pandemic.
Any more questions? I have one, and I think we have a couple of minutes, so I will go ahead. My question is, which assumptions were put into the imputation process, and did you find as a result of the imputation something that was expected given what you had seen in comparison with baseline variables?
So in the imputation model that I showed, we didn't put any assumptions in. However, we had done a more detailed analysis of missing ethnicity in our previous paper, which just looked at risk factors for COVID death. And in that model, we put in weighting for different regional proportions of ethnic groups in different parts of the UK. And we found it didn't make any difference, which is why we stuck with the most basic imputation, which had no assumptions. So I think I probably was expecting it to have some more effect, given my feeling that people who don't have their ethnicity recorded are systematically different. But I think perhaps for infectious diseases, which required kind of acute presentations, maybe those differences in health attendance were less apparent. So not only did people who have, a COVID exacerbation have to go to the hospital, all people were also attending primary care less. So those differences in health-seeking behavior were sort of flattened over the pandemic. So I think that's one reason why we didn't see an important bias with missing ethnicity for this particular research question.
Thank you. Any other question? Okay, so I will ask another one. I think we have until like 3 more minutes, so that's why. This is my question, and I think it's for Christopher. I am aware that in the US, there is also a use of imputation for race ethnicity. And I was wondering whether it is like in this study for a specific scientific question, or does it work differently?
Yeah, so I am fortunate enough to work with the Veterans Health Administration and have access to the full corporate data warehouse. We don't have as much of a problem with missing race and ethnicity in the VA as we do in other data sources. So we haven't really done a full-fledged multiple imputation or any imputation on missing race ethnicity. So I wouldn't be able to comment on that.
Thank you.
We've got good data in the VA.
Yes.
So one thing I will say, just picking up on what we do have available in the VA and the estimates that came from a slide that Rohini showed earlier, is that we don't have, I'm not aware of any US data source that has linked health information, EHR, claims data, to finer categories of race or ethnicity that could give us more of the granularity that Rohini and us over here in the UK are able to show in terms of the 16 various categories versus the 5 grouped categories. And so some way that we get around that, and this is a very imperfect proxy for studying not only racial and ethnic minorities and health disparities, but variations across the large region of America, is to do an interaction term between race, ethnicity group, and whatever granularity of data you have for region. And so we were able to see something in our data that Rohini didn't show, was there was massive disparities just looking at the divide between, for example, Hispanic veterans and white veterans and their disparity for testing positive. The variation across broad region of America was vastly different, almost like a 4-fold increased risk in the West compared to I think 1.5 or 2-fold increased risk at one time point in the South. So again, we are only able to assess disparities with the data we have. But I think there are some novel strategies, such as interacting geographic region and ethnic and racial group, that can kind of tease out what are the hypotheses that we can try to test in more granular data.
That's quite interesting. And I hope we'll have time to perhaps dig into that in the later Q&A session. It's really interesting. There is a question from Tanavich. I hope I am not killing your name. The question is there any potential indication bias due to different ethnicities, since you mentioned health-seeking behaviors in DAGs? I think this is for Rohini.
Yes, so I am going to be giving a longer talk on this study on the 25th in the main conference, but I think, I'm not sure if it's indication bias, maybe selection bias, maybe they're the same thing. But we found actually in our study, one of the first outcomes we looked at was ethnic differences in receiving a test for SARS-CoV-2. And we found that some ethnic groups, so basically in the South Asian group, Indian groups more likely to get a test, but Bangladeshi and Pakistani groups were less likely to get a test. So there is already a difference in behaviors, which then influences the actual risk of having the outcome. And so we hypothesized that maybe it is related to the fact that people of Indian ethnicity are somewhat overrepresented in medical and health professional settings. So in the first wave, it was health professionals who were getting lots of tests and lots of test results while everyone else was told to stay at home. So particularly if English isn't your first language, or if you're older, or even if you're a new migrant, you may not be aware that you were allowed to go see your GP, because there was very strong messaging to not go seek healthcare unless you absolutely had to. So we've got these two opposing forces. So higher testing amongst people in healthcare professions, lower testing in the rest of the community. And so I think there is that evidence that health-seeking behavior was influenced by policy and practice, particularly in the first wave.
Thanks for that answer.
My pleasure.
If there are no more questions, and I don't see any more, we'll take a break and we'll meet again at 50 past. So that's a 7-minute break. See you soon.
Okay, let's get started. You're on the title slide. The topic of this presentation is scalable, computable algorithms for identifying patients with health outcomes of interest, such as COVID-19, using electronic health record data. Next slide shows us the study teams that are working on this project. There are many. It's being led by 2 data contributing sites, Vanderbilt University and Kaiser Permanente in Washington, but there's others involved from Harvard Pilgrim Brigham, Duke, and the FDA. The next acknowledgement slide also gives you the participants in another study that looked at anaphylaxis as an outcome of interest. And we'll be using and presenting some of the data from that study as well, so I wanted to acknowledge those folks. Our outline slide, to give you a sense for where we're going today, is to present the motivation for this work, to talk about data-driven algorithm development approaches, and then we'll share some data from the COVID-19 project to date on cohort identification, primarily measuring exposures, covariates, and outcomes, and then a little bit on model development. This is a 2-year project. We're still in year 1, and we're still on the cohort identification stage, but I can give you a map of where we're heading in that project. So on with the motivation. Then go to, it should be slide after the motivation outline slide. So as many of you know well, the primary motivation for developing automated algorithms is to advance epidemiologic knowledge, at least for our audience. And the availability of huge amounts of structured claims data and data recorded in electronic health records, or EHRs, makes these kind of algorithms possible. repurposing these data sources to advance epidemiologic knowledge is a form of secondary use. And it's important to understand this. Secondary use is using data originally created for some other purpose, such as reimbursing providers for the cost of delivering healthcare, claims data, or documenting patient care in EHR. And secondary use of EHR data for epidemiology presents certain challenges. It's not surprising given that the data are being repurposed, but it's important to keep those challenges in mind. And some of the benefits of these secondary data are that they're relatively inexpensive, and they're also available in vast quantities. So it's kind of a plus and a minus. Now, if we can go to the next slide with the 3 circles in it, some of you are also probably familiar with ARIA, or the FDA's Active Risk Identification and Analysis System. It's a system designed for post-market safety surveillance. As shown in the black and dark blue circles here, ARIA has 2 main features. One is a set of predefined, parameterized, reusable analytic tools that do things like query data and conduct analyses. And the second component is the Sentinel Common Data Model. It consists of electronic claims data, or its equivalent extracted from EHRs, structured according to a very well-defined data model. And it is used with the tools to conduct analyses. And they allow these 2 tools, they allow the Sentinel to quickly and easily execute distributed programs across a network of multiple data partners to perform the analyses. Next slide, please. This slide illustrates how ARIA is used. When there's a serious safety concern, which is represented by the red square, that falls under FDA authority, the FDA considers whether or not the Sentinel ARIA system is sufficient for assessing that safety concern. If ARIA is deemed sufficient, that's the upper path going to the right, then the safety analysis is conducted in Sentinel using ARIA. If it's not considered sufficient, that's the lower 2 paths, then the FDA can issue a PMR, or a post-marketing requirement, and that the sponsor, often a pharmaceutical company, will conduct a post-marketing safety study. And then another option is this ARIA-related study. But the key point here is that a lot depends on the question of whether the ARIA system is sufficient. When we go to the next slide, we'll see here there's several reasons why ARIA might not be sufficient. The boxes in this slide present results of an evaluation that the FDA conducted of over 200 safety issues, about half before FDA approval was given and half after. And this analysis identified various reasons for insufficiency. As you can see in the red boxes, ability or inability to identify a relevant study population was one issue. Inability to measure exposures and to measure covariates was another. Sometimes the study required analyses that ARIA tools just weren't able to perform, which is the bottom squares in the red. But the most common challenge, which appeared in 70% of the cases where ARIA was insufficient, was the inability to accurately identify the outcome of interest. For example, whether patients truly had anaphylaxis. In the COVID-19 work I'll share with you today, we have 2 objectives. One is to develop algorithms for identifying COVID-19 patients. But then the second one, while developing these algorithms, we'll also be developing methods and tools that may be much more broadly relevant to Sentinel in an attempt to improve ARIA sufficiency. Okay, so that's all I want to say about motivation. Let's talk about the data-driven algorithm development. While I take a drink of water here, sorry.
Should I move on?
Okay. Hello?
Should I move on with the slides?
Yeah, please. After the blue outline slide is data-driven algorithm development slide. Excuse me. But first, what is an algorithm? simply put, an algorithm is a computable formula applied to data that yields actionable information with some known performance qualities. Diagnoses of diabetes or anaphylaxis are examples. Also, just capturing information about a patient's tobacco use history is another example. And algorithms can yield binary measures, probability scores, or categorical classifications. Next slide, please. Automation is important in algorithm development because it can improve scalability. And improving scalability means that we can execute these algorithms in multiple sites more easily and over very large data. And then another important issue is enhancing the replicability of these algorithms. If we can use data-driven methods to develop algorithms, it reduces the operator dependence during the development process, and also thereby gives us more consistency so that we're actually comparing apples to apples in various settings. Next slide, please. It can be helpful to think of development approaches as existing on a continuum with completely supervised or automated approaches on one end and completely supervised or manual approaches on the left here, and completely unsupervised or automated approaches on the other end. Manual or supervised approaches can be the best approach for developing simple algorithms, but they require a substantial amount of informatics and clinical expertise, and they can be time-consuming. In the past, most algorithm development efforts have tended to be toward the supervised or manual end of the continuum. But there's some interesting options now available for unsupervised or semi-supervised algorithm development, where yeah, so let's see. Does your slide have the 3 steps of the NLP process here?
Yes.
Hello?
Now.
Yeah. Oh, okay. I'm sorry. So let me just step through a little bit of what we mean by a supervised or manual process here with natural language processing. In the first step, and I guess there's quite a bit of automation here, so you're going to have to kind of guess where I am. I'm sorry about this. The first step is assembling a corpus, and that involves extracting clinical notes from an electronic health record. The second step in the middle here, red label create gold standard, is the manual to create a gold standard to identify who is and who's not a patient with a condition of interest. And then the third step on the right is this iterative process of engineering NLP features and engineering algorithms, where we develop dictionaries, manually specify some logic, possibly also using some, applying some machine learned algorithms, incorporating those into the system, and then coming up with an NLP pipeline that will process the corpus and generate the structured data. And you can see here, I think if you click the last time, you'll see an example of a manually created dictionary, which includes, it may include things like misspellings of anaphylactic shock as shown here. The next slide compares some of the supervised manual approach on the left to the unsupervised on the right. So you might need to advance through, but I just want to say about the supervised approaches, or the unsupervised approaches. They are data-driven. They use automated approaches to engineering the features that are needed. So automated approaches to developing NLP dictionaries, automated approaches to selecting the features that will be used in a model. Instead of using gold standard data, they use silver standard data, which we'll talk about. They can be faster, and they can be much more operator independent. So what I'd like to do is talk about some of these on the next slides, next few slides, talk about some of these unsupervised or automated approaches. Here is an automated feature engineering for phenotyping, or the AFEP method that's described by you and colleagues in a paper that's cited there on the bottom of the slide. This is an interesting approach where instead of relying on clinician experts or doing chart review to figure out what concepts are relevant to a particular outcome, a set of knowledge-based articles about the outcome of interest. So in this case, this is from the Anaphylaxis Project. Here's, the Medline Plus, the Mayo Clinic, Wikipedia, so forth, articles on anaphylaxis. We start with those articles. We take all the text in those articles and can make a corpus out of it. We, according to the AFEP method, then process that text with an NLP pipeline that identifies all of the SNOMED CT terms. So standard nomenclature of medicine, clinical terminology, dictionary terms that are appearing in that corpus. And then anything that shows up in at least 3 of them is considered to be a term that would be important to include in an NLP dictionary. You can see here on the right, there were 367 unique SNOMED terms in these 5 articles about anaphylaxis, and over 90 of them appeared in 3 sources. We can see this on, we actually included a 6th source in our implementation of this, so that's why some of them appear in 5 or 6 articles. But you can see here that in black, the terms that are most useful. You can see in red and yellow the term we started with, the concept we started with of anaphylaxis. You can also see some terms in blue where they're non-specific: diagnosis, cell, disease, complications, and so forth. And by manually reviewing these, the results of this output, these 90 terms, we come up with what is a dictionary that will be used for NLP. So that's the AFEP method, a way to automate an important step in algorithm development. On the next slide is the SAFE process, or the surrogate-assisted feature extraction approach. This is also described by you and colleagues in the paper that's cited there. And it's designed to select features that can then be used to develop a parsimonious model. So you'll have to start clicking through here, but it's applied to both structured and NLP-derived data. And it uses a silver standard surrogate instead of a gold standard to guide the selection of these features. Now, in the AFEP and SAFE and other papers by you and colleagues, a silver standard that's often used is like the count of diagnosis codes for a particular outcome, let's say diabetes or heart disease, that appear in a patient's record, with patients that have a high count of those being considered silver true cases, and patients with very low counts of those being, or no counts of those being silver non-cases. And those, that silver standard is then used in a sparse regression model. So this is where we get to the 3rd symbol over in the chain here, ensemble sparse regression, to select predictive features. So once those features are selected, some of the candidate features are excluded. The other ones that are remaining are then finally in the orthogonalized step are denoised to keep only the features that contain signal that's over and above the signal conveyed by the silver standard surrogate itself. So this again is a process that we have not applied in the COVID-19 study. We'll soon be doing that in the COVID-19 study, and we're currently applying it, but don't have results for another algorithm in FDA Sentinel that's looking at acute pancreatitis. The next slide I want to show, let's see here. Oh, I think maybe I can help figure out when to click. Yeah, so there's another approach I'd like to introduce is sort of a soup to nuts approach for automated development of algorithms that is semi-supervised rather than fully supervised. it's this CCAP approach described by Zhang and colleagues. And then after we describe this, I'll contrast it to another really interesting approach called the phe-norm approach described by you and colleagues. So the first click described here the filter. And the filter again is can be any silver standard label to get someone potentially into the study. And if we click again, from the study, we'll develop a data mart of structured and NLP-derived data. An NLP dictionary may be used by the AFIP method or some other, by the AFIP method, yes, definitely in the CCAP approach. And then the algorithm development in CCAP, what's unique about it is it incorporates expert curation. And so, for example, if there's some diagnosis code that's really helpful, or some procedure that's really helpful for identifying true cases, then CCAP does go ahead and specify and include that among all the other features that you're going to let the machine learner take a look at, likewise with NLP data. CCAP also requires gold standard data. So instead of using a silver standard entirely to develop the algorithm, it incorporates the gold standard data and also leverages that. If we click, so this is why it's called this, this is the supervised portion, the gold standard is the supervised portion of the CCAP method. Now, in contrast, if you click far enough, you'll see phenotype algorithm normalization, or phe-norm, which is totally unsupervised. This is the work by you and colleagues. Clicking again, you'll see that phe-norm does not use expert curation or review, and it doesn't use gold standard data. It relies entirely on a silver standard. And then even the algorithm training itself, if you click again, is unsupervised and uses mathematical formulas rather than gold standard to figure out how best to optimize a model to yield probabilities for true cases and non-cases, and then or probability of being a true case, and then where to define that threshold between true cases and non-cases. So if we go to the next slide, we'll do a little summary here on phe-norm versus CCAP. They both leverage silver labels for presumptive case definition early on. CCAP also uses gold standard data. They both use structured and NLP-derived data and use automated feature engineering. CCAP only incorporates domain expertise, and automated feature selection is used in both models. One is therefore unsupervised phe-norm, and supervised, semi-supervised for CCAP. Because phe-norm doesn't require gold standard data, you don't get performance metrics. You'd have to then go and create a gold standard and apply the phe-norm algorithm to it to see how well it performed. You get this in the CCAP method. They both yield a classification score. Okay, so to summarize on the next slide, data-driven or strengths and limitations. The strengths of these on or semi-supervised approaches are that they're highly scalable, they reduce the time and effort required. They're replicable, not dependent on how well a given person might manually create algorithms. They have demonstrated performance in many health conditions, such as chronic, common chronic conditions, and they reduce the need for clinical domain expertise. Limitations, however, are that it's unknown whether these methods perform well in rare acute health conditions of the sort that are often of interest to the FDA, or including COVID-19. And as I mentioned, phe-norm doesn't yield performance metrics unless you go onto the extra step to create gold standard data. Okay, so that's all I wanted to say about algorithm development in the abstract. Let's now talk about developing algorithms for COVID-19 and cohort identification.
David,
So,
you have 10 minutes left.
Okay, thank you so much. What I'm gonna let's jump to the next slide, the high sensitivity filter slide. the objective of a high sensitivity filter is to identify patients who are candidates for having a condition of interest. And we want that to be sensitive, but it may not be perfectly specific, of course. And so if you click once through here, you'll see we could filter in potential cohort members using any kind of data we want, diagnoses, procedures, et cetera, and then use a model to determine which of those are true cases and which are not. If we go to the next slide, we could see, if you click once, for acute pancreatitis, diagnoses alone may be a good filter for identifying potential cases. Click again, anaphylaxis diagnosis codes or procedure codes. We might add another data type. For COVID-19, we don't really know if you click twice. And so what we're doing in the COVID-19 project is we're applying this data-driven approach to many different kinds of data to see which might be useful for including in a filter. If you click again, we don't know how this is going to turn out yet. Some of the circles on the left may actually overlap, some be larger or smaller. But this is the general approach that we're going to take to identify these potential cohort members. Go to the next slide. I just want to say a couple of things about the dimensions of cohort identification. Of course, regardless of the condition, there could be severe, moderate, or mild presentations. The strength of evidence that is available clinically could be also on a continuum from suspected, probable to confirmed. In the WHO's definition of cohort COVID-19, these two dimensions are used. And then we might focus on a given area, such as severe and moderate disease that's probable or confirmed. Another thing we could do is add other dimensions. For example, we could consider whether the presentation was in the ED setting or the outpatient, and we might, for example, focus entirely on an ED or inpatient setting for algorithm application. Okay, I am going to, in the interest of time, skip over the sampling slide. There's nothing unusual there except to say that sometimes we want to stratify our sampling. Let's go to to introduce the COVID project here on. So I think, could you skip down to the the slide that introduces the study, advancing scalable natural language processing approaches for unstructured electronic health record data?
Do you know which slide number that is?
I think it's down 2. It's after, yeah, so maybe it's slide 28.
28.
Okay. I just wanted to mention here again, the goal of the COVID-19 study is to integrate EHR data and machine learning into algorithm development. We're focusing on COVID-19, but we're doing so in a way to improve cohort identification, exposure, and covariate measurements and outcome assessments. And then if you go on to the next slide, so just briefly, you see the 2 study sites here, Vanderbilt and Kaiser Washington. Vanderbilt, heavily inpatient, lots of encounters, lots of COVID, and likewise at Kaiser, lots of encounters for COVID, but predominantly outpatient. We can now skip back up to the 3 slides, up to the data-driven approach to specifying a filter. And this is where I'd like to, this is the slide with multiple rectangles on it. Yeah, you see this one. The first one is specify silver case definition.
Do you have the number?
It's probably 28. I'm sorry, 26.
You have 5 minutes, David, where I find 26.
Okay. So this one I want to walk through pretty carefully. So this would be right, I think this is right after the sampling slide we skipped over. Sampling was 25, and so this should be 28 or 26.
We are in 26.
Okay, good. So, okay, so this is the a data-driven approach that we're developing in the COVID study, and we think this might be useful broadly. It starts with a silver case definition if you can click once. And in our case, we're using the U07.1 diagnosis code for COVID-19. Click again, then we would select any qualifying encounters, and you can click again and see there were over 20,000 at Vanderbilt and 17,000 at Kaiser. Click again, and I just want to say the assumption here is that if you have data from several thousand silver cases, and you analyze those data and compare them to people who don't have that silver case definition, this is a way that could reveal criteria that could be relevant to identifying a condition of interest. And it's important to understand here is this is not saying, yes, Mr. Jones or Mrs. Smith does or does not have COVID-19. The objective here is to say, what data is likely to point to people who really do have COVID-19? Click again and we'll see that the next step is describe the co-occurring EHR data. And click again for each co-occurring data type. So we look at encounters with a U07.1 COVID-19 code, and then we say what other data is co-occurring with that same encounter. And so we could look at the frequency of these other co-occurring data, or importantly, the relative frequency. So how often it occurs for silver encounters versus everyone else. And then we could also do things like say, well, if we added this feature to our filter, how many new patients would it yield? And then finally, if you click again, there's a manual review process. There could be many distinct criteria, and the filter would include patients that met any single filter. Okay, so in the interest of time, I'm going to talk about this, applying this in the case of diagnoses. But then we'll skip over the others. And if you're interested, you can look at the slide deck to see how this applies to problem lists and labs and so forth. And Andrea, about how much time do we have here?
I didn't understand your question. Can you please ask again?
Yeah, about how much time do we have left?
I have 1 minute for your talk, but I think we could take perhaps the 5 minutes of the Q&A. So you have 5 minutes again.
Okay, so I'll walk us through the slide, and this will be the last thing we present here, and it'll give you a good sense for how this process works. So we should be on slide 29, relative frequency of diagnoses on the date of a silver encounter. And what we see here is we selected encounters that had a U07.1 diagnosis. There's 2 columns for Vanderbilt, 2 columns for Kaiser. The ends in there show 22,657 for Vandy and 17,507 for Kaiser. All of them have the U07, but what's interesting here is what else do those encounters have? And in red, we see diagnoses because of their high frequency, and these are sorted in descending order of frequency, are candidates for including as filters. So Z20 in the second row there, Z20, contact expected other viral communicable diseases. Okay, could be a good one. The 4th row in the table, another one, actually specifies COVID-19, also relevant. And it's notable that when you use a data-driven approach like this, you're going to identify things that are either not are emerging and becoming important, but they may not be in curated standard lists of things that are important. So the National Cohort Collaborative produced a list of codes that could be used to identify patients, and this one did not happen to be in it, probably because the collaborative produced its list before this this ICD code became widely used in practice. In green here, we see some other codes are also quite common, but not very specific. So cough or fever or shortness of breath. So those may not be good candidates. We could click the slide now. You'll see another table. This is just looking at Kaiser Washington data, but it gives us this relative frequency. Click ahead, a column on the right. So this is how common is this code in the silver standard U07.1 cohort versus everyone else. It also just shows any codes that appeared at least had a relative frequency at least 10 times greater in the silver cohort. You can click through, and you can see here in the blue column, it also gives you the number of new patients. Click again, you'll see in the top 5 rows here, pneumonia due to COVID-19. Okay, it's a different code, 2,000 times more frequent, obviously. But there's a lot here that can be used in order to develop a list that can then be used both, by an expert to take a look at this and say, oh yeah, these are good codes. And then with the data in blue, we can see how many new patients would be added. So you can get a sense for how common these things are. And if you click through, you see the second from the last row, acute respiratory failure with hypoxia. Okay, that sounds like COVID, but it can also be for other things. And if we add it to the filter, it adds 3,000 new patients. That's where I will stop. If you do, actually, let's just look at I won't present the slide, but the next slide plots the number of new patients with the relative frequency, and this can be super helpful for identifying candidate filter items to include that might help identify patients. Okay, I will stop there, and I apologize for the timing. It's a little off today, but let's entertain any questions that you all may have.
Thank you, David, and thank you so much for being mindful of time. We can take a question or two if they are quick, if there are any. I cannot see the chat screen at this moment. Is there any question written there?
I don't see any.
Okay. If there is time, could we present slide number 30?
We are in slide 30 now.
Oh, we are. Okay. So let's see. So slide 29 was the table. Slide 30. This is where we left off. Okay. I'm going to present it here. Okay. So this slide, these dots represent the same data in the tabular format we saw on the prior slide. So across the horizontal axis, relative frequency, and the red dots are all at least 10. So you can see that on the scale. And then on the vertical axis, how many new patients would be added if you included that diagnosis code as another element of your filter for identifying potential candidates for your phenotype. If you click once, you'll see J1281, pneumonia due to SARS-associated coronavirus. Okay, super high relative frequency. It only adds 9 new patients. That didn't, that means only 9 patients at Kaiser who had this code didn't also have a COVID-19 code on the same encounter. But why not include it? You'll include 9 patients who probably should be in your cohort. If you click again, you'll see the acute respiratory failure with hypoxia code. 11 times more frequent in the U07.1 cohort, but it adds 3,000 patients to the cohort just on that code alone. So you got to, this is where some of the decision making has to happen about what to include and what not to include. If we click again, and we can see here in the range of 2 to 9 times relative frequency, there are lots of diagnosis codes down in that region. If you click enough, you'll see the blue dots appear, lots of overlapping blue dots. And if you click again, you'll see a green box, down here in this lower region. So this, adds fewer than 1,000 patients, and it's, 7, 8, 9, 10 times more frequency. Though there might be some good candidates in there. Maybe less so if you click again and see the red box. So these are, yeah, more frequent than people who don't have the COVID code, but have lots and lots of patients. And then in the, click again in the opposing yellow squares, you know, kind of the gray area. Maybe they had too many patients, but they're fairly highly, have fairly strong relative frequencies relative to the non-silver cases. So, and these data would then be presented in a way that they could be the topic of discussion with a clinical expert to figure out what features we would actually include in the high sensitivity filter in a data-driven manner. That's all I wanted to say about that slide.
When do you think, David, your group will have a paper or a full presentation with this?
With the data-driven approach?
Yes.
Mm-hmm. And I'm sorry, did you say a paper that's already been published or in process?
When do you think you will be confident enough to apply this method and have a report that is public, or a paper or something where we can actually read how this continues?
Yeah, thanks, Andrea. So we will complete the cohort identification work for COVID-19 by the end of this calendar year. Actually, I think our deadline is January of 2022. And we certainly intend to write it up. It takes a little while to get things out that, you know, published, but we'll be sharing all this publicly on GitHub and other sites. So happy to share it at that time. Also, if anybody's interested in please reach out. At the end, at the last slide in this deck is my my email address, and then Josh Smith at Vanderbilt, who's the PI there, is also available to respond to any questions you may have.
Thank you very much. We'll stop here, but if anyone has questions for David, there will be time at the end of all presentations to discuss just anything. And now let's take a break and meet again at 40 past the hour. For me, it's 7:40. For others, it will be 1:40 and so on. Thank you, David, and thank you, everyone.
Thank you, Andrea.
Hello?
Hi, Sarah. We hear you.
Awesome. Can I try sharing or no?
Yes, go ahead. I stopped sharing my screen.
Okay. I just want to oh, you know what I realize? Okay, so I'm sharing. Does that work?
I don't see anything.
Okay. Then does
I mean,
that
I
work?
see you, but I don't see your screen.
Okay. Okay. Oh, maybe I didn't.
Oh, there we go. It says now it started. Yep, now I see it.
Can you see full screen?
Yes.
You know what the trouble is, though? I'm not sure I need to be able to see the Zoom, but like if I'm in presentation mode,
I know unfortunately it's not a Zoom feature yet.
Okay.
So they don't
that
have
all right?
presentation mode,
Okay.
but I see it and it looks good. It's like the
Okay.
right size and you're not showing speaker notes or anything. So
All right. As long as I don't need to see anything on the Zoom screen.
nope, it looks like everything's good to go and we'll handle the questions for you. So you don't need to worry about monitoring that.
Thanks.
Yeah, no problem. I say we, I mean, Caitlin.
Okay. I don't even know if I can
Me.
like mute right now because I'm.
Well, can you can move it though, right? Like you can move from slide to slide.
Yeah. I just can't see the Zoom, like I don't have all my Zoom controls or I can't see myself or anything like that.
Okay.
But I suppose I don't really need to mute at the moment.
Well, we can see it. So you look good. Your screen looks good.
Okay.
Everything looks a-okay.
Is the background working?
Yep, it is.
Okay, good.
Okay. So it's 40 past the hour and it's our time to start with Sarah.
Okay, great. Thank you. So today I'm going to present on long COVID, our study that's a collaboration across 8 integrated healthcare organizations where we find a high burden of healthcare utilization 3 months following infection with SARS-CoV-2. So just, can I forward the slides? Let me try clicking. All right. So what is long COVID? It remains a sort of difficultly nebulous condition. You can tell by the definition. This is from the CDC website. It's long COVID conditions are a wide range of new, returning, or ongoing health problems people can experience weeks after being infected with SARS-CoV-2. So you can see it's a pretty broad definition. According to WHO, more than 200 symptoms have been reported. There aren't really standardized lists of symptoms. So different studies use different lists. When does it start? So that's also not exactly clear. For example, the CDC website says 4 weeks after acute infection. IDSA, the Infectious Diseases Society of America, has 3 weeks. You know, we know that people quarantine for 2 weeks, and we've heard a lot about sort of the 14-day acute phase. So it's difficult to know when sort of the acute phase ends and the long COVID phase begins. The duration is also not particularly clear. You know, can last, and also it depends on the symptom, of course, and the patient. Some, you know, symptoms can last 3 months. It looks like some are lasting 6 months, 9 months. Obviously, since the pandemic is relatively new, we don't have super long follow-up on a lot of people. So there are sample size limitations for the longer follow-up times. But more studies are trying to increase their follow-up times to try to understand how long conditions can persist. Also, what causes it is not clear. We don't know who's at highest risk for developing long COVID, even whether there are certain constellations of initial COVID infection that may predispose somebody. A lot of these things are being worked on. There are quite a few studies on long COVID, but there's certainly limitations to a lot of the studies thus far. A lot of our most robust evidence comes from small scale studies. Many studies lack appropriate control populations, so some design issues. Studies are often limited to adult populations, and we know that, of course, kids can be infected as well. And a lot of studies have focused on hospitalized patients and sort of following this severe cohort over time to see how conditions persist. So because of this variety of circumstances, it really is difficult to extrapolate the findings to a broader population. of those with COVID, irrespective of initial disease severity and irrespective of these other kind of defining characteristics. So to these ends, it's difficult to know the burden. You know, probably a lot of us have seen in the media. I think there was something this past weekend from, I think it was like Sanjay Gupta was reporting something from somebody else about 30%, but it's very difficult when there's not a systematic definition, and to define long COVID is just very difficult. But we did set out to do this regardless. We did the best that we could, and I'm going to talk today a lot about some of the methodologic decisions that we made to try to make our study as robust as possible. So this study was conducted within the Vaccine Safety Data Link. So the Vaccine Safety Data Link is a large consortium. It's a collaborative project between CDC's Immunization Safety Office and 9 healthcare organizations that are distributed across the United States. The CDC, and this study includes all sites, almost all contributing data, but I think 1 or 2 not, and just contributing scientific expertise. The VSD started in 1990 and continues today to monitor the safety of vaccines and adverse events following vaccination. Since the pandemic, this sort of large, very well-oiled consortium, this machine that really functions well and can produce data quickly, has also taken on some new projects, which is sort of where this one fits in. It's not really a vaccine project, but is really able to capitalize on the advantages of the consortium. So the aims of the study were to, again, this is from a utilization perspective. So describing weekly counts of utilization across all settings for the 3 months following index date. And we have index dates in 2019 and 2020, which I will go into, for those who test positive and those who test negative. So we use an interrupted time series difference in difference approach to evaluate whether healthcare utilization increases in the 3 months following index date compared to a matched time period in 2019. So that's sort of controlling for the individual level factors, and then to adjust for secular confounding, which there's quite a lot of during this pandemic, comparing pre-post utilization to a matched cohort COVID negative population. And then we stratify our findings by some patient characteristics, time period following index date, and some long COVID syndrome types to explore the subgroups at highest risk of increased utilization. So this was a matched retrospective cohort study. We did include all ages. Our pre-period was from March 15th, 2019 to February 15th, 2020. And our post-period was from March 1st, 2020 to February 15th, 2021. And we did require continuous membership, allowing for a 31-day gap. And people always say, well, what's the gap about? It's just kind of a administrative. Sometimes people lose their membership due to administrative delays. So it allows people to kind of lose membership for a short period of time, but it doesn't mean they're not a member anymore. But from 12 months prior, and that's really to capture comorbidities, and to 3 months after the index date to capture utilization. Our index date was defined as the date 2 weeks following the positive test date. So for example, for somebody testing positive on May 1st, the index date would be May 15th. And again, this is to try to not include that acute phase of infection. Our COVID positive population was defined as those with positive lab test from March 1st to November 1st, 2020. The reason we've kind of gone back from February is to allow those 3 months of follow-up. Our assumption at the time when we designed the study was that analyses were going to start in February, which they started shortly thereafter. But as many of us know, things don't always go exactly as planned, but at some point you just have to make your decisions to freeze the data. So our COVID test negative population was defined as those with a negative COVID-19 diagnostic test from the same time period. And our test negative population was matched to the test positive population on VSD site. So from the map, the different sites, age, sex, race, ethnicity, and the date of test. Our outcomes of interest were utilization. So we looked at the utilization rate during the 3-month follow-up period. And we did this overall and by a few different characteristics. We looked at utilization rate associated with 46 long COVID syndrome diagnosis categories. So this 46 diagnosis categories was how we ended up defining long COVID for this study. It's this study, so the vaccine safety data link, I think it might have been just a small dot on that map, but it is funded by the Centers for Disease Control and Prevention. So this is in collaboration with the CDC, and we ended up talking to the long COVID task force and trying to work with them to use a definition that they had developed in order to try to enhance comparability across studies so that we could all start using some kind of standardized definition that more studies would use and that we could actually kind of learn a little bit better from. So we got our definition from the CDC with the hopes that others would as well. Hopefully that will happen. These 46 diagnosis categories were developed based on literature at the time. And so those are the ones we looked at. We used Poisson regression models with robust error variance to estimate the adjusted increase of utilization rate. So the ratio of rate ratios, and I am going to talk a little bit more about this. I know it gets a little confusing with the different times and the not positive and negative. So we do have some graphics there associated with COVID-19. And then I think a piece that's really useful for healthcare organizations in particular, especially those on the planning side, is we calculate the volume of excess visits attributable to COVID-19 as an adjusted difference in the frequency of visits between COVID positive patients in 2020 versus 2019. So just trying to get a solid number on what will this look like? How many visits can we expect in this follow-up period? We did collect other data on clinical comorbidities, such as these listed here. And even though our interrupted time series approach removes the need to adjust for these comorbidities because we're really looking at a pre-post comparison, so adjusting for those things in the same individual, it is possible that the COVID-19 positive population differs from the negative population on the prevalence of some of these factors that may also be associated with utilization. So we really use these more as a like strata for subgroup analyses, but not necessarily for adjustment. And these were also from the CDC website for high-risk conditions. Okay. So first, we identified those with a positive COVID test. Again, this is just spelling out a little bit more clearly what I said before, from March 1st to November 1st. And again, that allows us that time for you look at utilization because we were supposed to analyze in February. We define the index date as the date 2 weeks following the positive test. And this allows that 2-week washout immediately after the positive test. And then we look back in 2019. So based on the index date, we defined a 3-month corresponding time window in 2019 for each patient. So for example, if a patient developed COVID-19 on May 1st and the post-index date period would cover May 15th to August 15th, and then we would use that same period of May 15th to August 15th in 2019. And because we're analyzing utilization within the same individual, and that's comparing B and A, we really adjust for healthcare seeking behavior, health status, and other characteristics that are really important in this kind of analysis. And then we identify a COVID-19 negative. So these are people that tested, but tested negative, population matched 1-to-1 to COVID-19 positive patients. We define the index date as plus or minus 10 days to the date of the COVID-19 positive population. And then similarly, as we did with the COVID positive population, we identify that 3-month corresponding time window in 2019 anchored on their index date. And so by adding this C and D component, we are adding an adjustment for secular confounding, which has been, again, very dramatic during this period. And for example, you can imagine that even for people that test negative for COVID, they may have utilization changes in 2020 compared to 2019. I mean, at least where I sit at Kaiser in Southern California, there were tremendous changes in the way we delivered healthcare across, and it wasn't just for people with COVID. It was across the whole patient population, you know, for many of us, a switch to virtual care, et cetera. So you really do need, I think, this kind of consideration in your study design. So this is just the same thing again. So the ratio of the rate ratio tells us the excess utilization attributable to COVID-19. And again, A and B is comparing utilization in the same person pre and post COVID-19. And then we use the uninfected group to adjust for secular confounding. So we have adjustment for fixed effects, health status, healthcare seeking behavior, other things that we may not be able to completely adjust for if we were to just use variables in a model, and time varying effects such as secular trends. And then we get our RRR, which is our estimate of interest, which is the adjusted rate ratio associated with COVID-19. Okay, so what did we find? Well, first, here's our study population. You can see the positive groups and the negative group is balanced because we did a matched approach. We also matched on race, ethnicity, age, and sex. So those look balanced. So that's pretty good. And time of test. So we're getting good balance there. These are just a few of the comorbidities that we looked at. You do see a little bit of a difference here. Where the test negative population actually has a little bit of what looks like of higher comorbidities compared to the positive population. Otherwise looks good. And then I'll also add that combined, we actually identified 130,184 positive patients. So not too many more than what you see here. So it's a very small number of patients that we couldn't match. So we really were able to match pretty much the whole positive population, which is good. Okay. So here's the overall 3-month utilization for COVID-19 positive and negative populations in 2019 and 2020. So I actually have to orient myself sometimes on this one. So the solid line is 2020. The dotted lines or the dashed lines are 2019. And then the green is COVID positive and the brown is COVID negative. So actually, potentially counterintuitive, what it looks like overall is that the negative group has a higher utilization than the positive group. And this, to me, really highlights the strength of this method. This is clearly something we do need to adjust for. And this is likely due to higher comorbidities in the test negative group. The negative group was tested for COVID-19. They did test negative. It's possible they were sick or symptomatic. They could have had procedures that required testing, but I think what we've seen overall, at least with testing behaviors here, is that sometimes people that have a lower overall health status test more. They're more concerned about their health for reasons that are valid. They have more encounters with the touches with the healthcare system. And so I think this is something that really just highlights the fact that we do need to use a difference in difference approach if we're going to look at this, because it's probably not what most people would expect. And even after the negative test, you can see a little bump in utilization even for the negative group. So this is just stratifying by healthcare setting. So this is the COVID-19 positive group. 2020, of course, because they're positive. There wasn't COVID-19 in 2019. So we can see a lot of the care after diagnosis was virtual. It continued to be quite a lot of virtual utilization, and then outpatient care became higher after about 4 to 5 weeks. And then you can see there's sort of a modest decrease in ED and inpatient use in the first 3 weeks. It's a little, the scale is being driven by virtual care, but there is a slight decline there as well. So for the negative group, there's also a bit of a decline after the index date for virtual and outpatient care, even for those that tested negative again. And ED and inpatient remained relatively constant. Okay, so when we start putting these two things together, 2019, 2020, positive, negative, we have our difference in difference estimates. And what we see here, starting at the top, is that we do see overall encounters are higher for those associated with COVID-19. Outpatient encounters go down, but a lot of the other settings are increased, particularly ED and virtual. A lot of the visits seem to happen in the more proximal time to the index date. We see that the age group with the most utilization are those 50 to 64. Non-Hispanic Asians seem to have high utilization, and these are just select comorbidities that we looked at because they were the most prevalent, but underlying comorbidities also are associated with increased utilization after COVID diagnosis in the 3 months. So when we look by condition, we see quite a few were quite elevated. Pneumonia, bronchitis probably makes sense. Actually, a lot of it makes sense and is consistent with other studies. Disorders of taste and smell, hypoxemia, hair loss, shortness of breath, nervous system disorders. Those are sort of, very large increases in utilization in the 3-month follow-up. What we see here are the ones that were statistically significant. Remember, we did look at 46 conditions. These are the ones that we saw a difference. I have a slide later just showing the rest of them just for the interest of being thorough, but these are the ones that we saw an effect. Coronavirus was actually one on the CDC list, and we didn't include it here on this forest plot just because it's an enormous number, 41, and it sort of just it was difficult to read everything else, but that one also, of course, was associated with increased utilization, and yeah. A couple had lower, not very many, lower utilization. So this is just stratified by the proximal period and the more distal period. And while some conditions declined in utilization after 6 weeks, so it'll be a little difficult for you, I'll just list them: cough, fatigue, muscle weakness, infectious complications, pulmonary embolism. Some persisted with high rates of utilization, disorders of taste and smell, hypoxemia, pneumonia, shortness of breath. Those are ones that just continued through both time periods. And some actually worsened in the more distal time period, including DVT, deep vein thrombosis, and hair loss. This is just to quickly touch on children. These are what we saw for children less than 18. Not too much, thankfully. Not a lot of evidence in our study of increased utilization post-COVID, except for infectious complications. But I'm going to talk a little bit about that in my conclusion slide, which is coming soon. And this is the excess utilization slide that I mentioned, just calculating a volume, just putting a number to this. So how many visits do we expect to see? So for example, if you look at the top row, about 20,000 visits in 3 months for what we have is about 130,000 patients. That's quite a lot. That's a lot to absorb. I think a lot of healthcare organizations are really staffing up and planning for, the acute phase, making sure we have ventilators. A lot of focus has been on that. But I do think I think these data show that long-term planning is also probably a good idea. And if you look here in the inpatient and emergency department, some of these are actually quite high numbers. That also impact high resource settings with a lot of use. And this is only for the first 3 months. So quite a large impact that we see. These are just the conditions I mentioned that are not included in the forest plot because they were not significant in our analyses, but they were analyzed. And then just some conclusions. So again, the volume of more than 20,000 COVID visits among 130,000 patients over 3 months parallels ongoing strains in healthcare resources. And these strains that are ongoing are due to concurrent new COVID infections. We have obviously the situation we have with Delta, as well as increasing loads of non-COVID related care. A lot of people have deferred preventative and routine care since the inception of the pandemic, and we're just starting to see the impact of that. So, really planning for this is really important. Several of the long COVID conditions that we saw with elevated utilization were consistent with those identified by the CDC and others, but we did find moderate associations between COVID-19 and headache, anxiety, or sleep disorders, which had been previously identified as some of the strongest associated symptoms of long COVID. And I think one kind of highlight here is that those studies in general lack control groups. So when we lack control groups, we can overestimate these, especially these types of symptoms, which can often reflect overall pandemic related stressors felt by all, rather than those causally associated with COVID-19. So just a little perspective on that. COVID-19 attributable utilization was higher among patients with underlying health conditions. We know that those conditions are associated with higher risk of getting COVID, but they also may be associated with long-term utilization. We found an overall reduction in healthcare utilization following for children in the 3 months follow-up. But I do think the analyses on children need to be sort of taken with a grain of salt, because the list of conditions that we used or that CDC developed was based on existing literature at the time. And there has been very limited literature on children. And so I personally think a study that specifically looks at conditions that are more likely to present in a pediatric group would be very important, as opposed to trying to fit those into, but we still wanted to include children just to, try to expand our knowledge on this group, because it's just so limited. And then, I think this study offers new perspective. A lot of the prior studies are frequently specialty specific. So neurologic specific, we're looking at neurologic symptoms or cardiac. I think I'm 2 minutes over. So do not have control groups, et cetera. Use self-reported outcomes. That's a lot of them use web-based tools where you report on your symptoms over your phone, et cetera. But we know from many studies obviously those are subject to bias. Those are subject to who tends to, have a smartphone, who tends to enroll in these things. We know that women tend to enroll more, and it's possible that people that are more likely to be experiencing symptoms are more likely to participate as well. So self-reported outcomes definitely have their limitations. They're great for a lot of things as well. But a lot of, these are just other limitations of other studies listed here. We do hope to extend the study for a longer follow-up. I'd probably like to do a sensitivity with an index date starting a little bit later, and then also assess the risk of long COVID by severity of COVID, initial COVID, the acute infection, and other potential factors. And that's it. Thank you.
Sarah, thank you very much for this presentation.
Yeah.
We have one question from Stanley Etlavich, and I will read it now.
Okay.
The question is, the encounter slide showed 20,000 excess in 3 months, and it also showed over 80,000 coronavirus encounters. So how are these numbers related?
Let me go back. That is a good point. We had updated these analyses a little bit at the more recent time, so it's possible that I did not update this top row. So thank you for pointing that out. I think this is this is I think, oops, sorry. This is likely the old estimate. I agree. I think I did update these, and this would probably actually be much higher. Thank you.
It makes sense.
Yes, definitely. Good question. Good catch. Quick slide.
There is another comment, another question from Pooja in Joshua. Terrible pronouncing, I am sorry. The question is, what were the case numbers like for conditions that were not significant, the conditions that were not in the forest plot?
Oh, that's a great question. I mean, it's such an enormous number of tabs in an Excel sheet. I think, you can see it's such a wide range of conditions. They're likely just going to differ tremendously. I think some of these are probably less likely. Psychosis is one that I think has popped up in the media, for example, because it's kind of a media friendly condition, but some of these may be very common change in bowel habits. Then again, I don't know. It also probably depends on how often people actually seek care. And that's another kind of aspect of the study that I don't mention, is that it's possible that many of these are conditions that define long COVID, but we are really looking at it from a healthcare perspective, like what is actually hitting the healthcare organizations, what are people seeking care for? And that is a slight difference. That's the advantage of self-reported systems over this type of analysis, is that you can get more of those symptoms that exist, but people may not seek care for. So I think it's going to be a very wide volume difference between all these conditions.
I had a similar thought as you were going through this slide. I was wondering whether the conditions that were not significant were, which the reason was just uncertainty due to small counts, or possibly a likely null effect, if I can say that. And I imagine there is a variety among these very many conditions.
Yeah, but I think a lot of the ones that are significant also had pretty low counts as well. So I'm not sure if it's as much of a sample size issue as us just not seeing a difference between COVID positive and COVID. And again, it also may have to do with how people seek care for these conditions.
There's a follow-up question that relates to what you have just said, which is how do you deal with potentially psychosomatic or media influenced or media induced reporting conditions?
I mean, we included several mental health conditions in this. Obviously we can't really at this, this is a very high level look. I don't know if I could attribute it to media. I think there probably is a lot of symptoms that are being experienced outside of the medical, outside of the medical system that aren't being captured. I think probably a lot of those in particular are not presenting potentially in the study, but may exist, and you may be able to detect them through other means.
Thank you. We'll take a short break now. Thank you very much, Sarah. I have a couple more questions, but I will wait until the general Q&A session.
Okay, thank you.
Let's meet again in 5 minutes at 20 past. Hi, everyone. After this short break, we'll be restarting the course, starting our last presentation with Diego. Diego, please.
Thank you very much. Thank you, Andrea, and the organizing committee for inviting me to give this presentation. I'm going to be talking today about 3 large pregnancy registries that we are conducting in the area of COVID-19. Because this is a course, I will make it relatively interactive, and I'm going to be telling you what I think are the lessons learned from conducting these studies, what I would do again, and what I would not do again if I had to do these studies. This is the disclosure slide. The 3 pregnancy registries I will be describing and I will be talking about are the IRSEP study, which is our COVID disease-based pregnancy registry, the CVIPER study, which is our COVID vaccines-based pregnancy registry, and finally the COVID PR, which is our therapeutic COVID pregnancy registry. The goal of the 3 pregnancy registries is to evaluate the obstetric, neonatal, and infant outcomes amongst pregnant people who had COVID versus those who didn't have COVID. That's in the IRSEP study. Vaccinated versus unvaccinated, that's in the CVIPER study, and treated with COVID-specific medications versus treated with repurposed COVID medications, that's our COVID PR study. And the 2 cohorts, the exposed and the unexposed, are matched by country of residence, calendar time, and gestational age at the time of enrollment, if the sample size is sufficient. Ultimately, the objective of our pregnancy registries is to provide all stakeholders with the evidence they need to make informed decisions and recommendations. Our pregnancy registries are international, non-interventional, online, and either disease-based or post-marketing cohort studies conducted during pregnancy or until the baby is 12 months of age. This slide shows you on the left the recruitment that we have up to today in the IRSEP, our COVID disease pregnancy registry. And on the right side, the enrollment we have as of today in our vaccine-based pregnancy registry, the CVIPER. As you can see, we enrolled 18,000 participants in 6 months in the IRSEP study, and we enrolled 8,000 participants in 10 days in the CVIPER study. The tables below show the top 10 countries in terms of enrollment. For the IRSEP study, we have 69 participating countries. In the CVIPER, currently, we have 44 participating countries. So both studies are truly international. The COVID PR study has not launched yet and will be launching in October. And I will be discussing 6 particular topics briefly today. The first one is the approaches that we recommend to follow to contact potentially eligible pregnant people globally. We will be talking about data quality, how to validate and verify the data when you are conducting an online international study. We will be talking about the technologies to collect data in that context, about the collection and reporting of adverse events, about techniques or strategies to increase participant engagement. And finally, we will be talking about the so-called study master file. So let's start talking about how to identify and contact potentially eligible pregnant people globally. You don't have to read all these bullets. I will be discussing them, and I will be showing you some examples. First of all, we do it through social media. We are a 100% online study, and we identify the potential participants through social media, globally, internationally. We discovered that for the pregnant population, Facebook and Instagram are superior to other different types of social media, such as Twitter, TikTok, Snapchat, or LinkedIn. And before the start of any social campaign on Facebook, you need to do your research. You cannot just publish an ad and hope for the best. You need to think, in what cities do most young people live? You are looking for pregnant people. What languages do they speak? So for example, you might be interested in launching your study in India. In India, there are 18 languages that are spoken, and some more frequently than others in different regions. If you are in Delhi, you might be interested in English and Hindi. If you are in Mumbai, for example, you might be interested in Marathi, so on and so forth. So you need to do your research depending on the cities where you think there will be a higher prevalence of young, relatively educated population or population with access to internet. That's where you need to see what languages they speak, what images they like to see, what text you need to use. It may be different, a population in a certain region in New York City than a population in Calcutta, for example. So you have to do your research. How common is internet use in the population that is exposed in general? Is it frequent? Is it constant? Do they have interruptions? Is there a university where almost everybody uses internet close by? Is the exposure, maybe the medication or vaccine that you are interested in studying, known to be available in that area? Not only available because it may have an emergency use authorization, but because also it may be recommended or not for young people. So for example, Canada nowadays is not allowing young people, including pregnant people, to receive the AstraZeneca vaccine. Similarly, and the vaccine is approved in Canada, but the young people cannot get it. Similarly, in the UK, that's happening similarly, and also it's happening in other countries in Europe and elsewhere. So it's not just enough to know the vaccine is available in certain countries. You need to find out if it's available in the population of interest. In our case, the pregnant population, the young population. And if the vaccine is not available in the young population in the countries that you are looking at, then maybe that's not the best place to go because there's no exposure. Similarly, when you are looking at a therapeutic, is the therapeutic, that monoclonal antibody, for example, that you are studying, is it available for the young population, pregnant population, for example, in hospitals in the region of interest? It might not be available. So you need to do your research. And finally, are there blogs, websites, parenting forums that young pregnant people follow? And the reason why you need to do that kind of research is that when you are going to do the targeting of your social media, those blogs, websites, and parenting forums can be of great importance. You are going to do your targeting according to where you think the pregnant population are within Facebook. So if they are following a particular rock star, or if they are following a particular podcaster or a YouTuber, that's the place where you're going to be targeting because you know that the pregnant population is there. So you have to do a lot of research before. And then the targeting must be done according to a careful research of keywords. How do you identify pregnant people? You cannot just say, I want to look for pregnant people and Facebook will find them for you. You need to do a targeting that is using keywords that are related to the characteristics of the pregnant population. Obviously, you are interested when you do your targeting in what Facebook calls women, young. You have to decide, is it young 18 to 40, 18 to 45, 18 to 35? That's up to you. And then decide the region and a variety of keywords that the artificial intelligence tools of Facebook is going to use to try to find those people with the characteristics that you want. You need to use the Facebook Pixel and Google Analytics because you want to track the ad performance. You want to know where are these people coming to your website from? Where are they located? You can get real-time demographic information using the Pixel and Google Analytics. That is very important to retarget your ad campaign. You have to be looking constantly at how your campaign is doing to decide, well, actually, maybe Chile is not that interesting. I should move to Peru. That is more interesting from an enrollment perspective. And the Pixel and Google Analytics will help you identify how long are people staying on the page, what sections of the page with the questions are people going to, where are they coming from. Also, when you are going to design your social media campaign, you should have several images of different styles. Some of them can be photos from stock, some of them can be Photoshopped photos, others can be cartoons. It depends on your style and your brand's style. And then try the different images and the different texts with different segments of the population, and then see their response. And ultimately choose the one that seems to be the most popular. If most people seem to be reacting positively to this image and this text, then that's where you will want to focus. And if people are not responding positively, or when you read the comments, people hated the image and they were very upset about the image that you chose or the language that you chose, then that's language you should discard or at least modify. Also, you have to be very much aware that Facebook and Instagram have very strict terms and policies. For example, for a long time, and I think even currently, if you use the word woman, the ad is going to be rejected on the basis that it's sexist. If you use the word pregnant, the ad is going to be rejected on the basis that you are talking about a physical characteristic. If you use the word COVID, the ad is going to be rejected on the basis that you are talking about a disease. Now, if you are if you are a charity, a non-profit organization, or if you are a university, you might be able to get away with that because Facebook has different terms and policies depending on who the advertiser is. But if you are a for-profit company, if you are an individual, and you are trying to use any of those terms, it's guaranteed that in a matter of minutes, your ad is going to be rejected. And Facebook will not tell you why they rejected it. They just tell you that they reject it. And then you will have to do your research to try to understand, did they reject it because the image was not good, because one word was not good? And then you have to start testing. If I take away this word and put another word, do they accept that one? And then you understand, oh, maybe it's because I used the word pregnant. Pregnancy, on the other hand, is accepted, but pregnant is not. Here you see an example of an ad that we published for our CViper, our vaccine pregnancy registry. As you can see, the ad is using a cartoon. You see the face of the lady getting the vaccine. She seems to be quite surprised in a way, big eyes, but actually this cartoon seems to be very, very well accepted by our population. As you can see, it had more than 1,300 likes, more than 2,600 comments. And the reason why I'm showing you this ad is that the ads in Facebook not only are helping you to spread the message, but people comment at the bottom of the ad, and then you can understand better your target population. Read some of these comments. And I just selected some, and look at the number of responses. On the right side, you see the number of responses of the likes, and below the number of replies. So these people are being very, very active when you are talking about pregnancy and you are talking about vaccines. And so, for example, the first one says, no, I haven't used the vaccine. I didn't get it. I don't know what it could actually do to my unborn baby, and I'm not going to risk it. And a lot of people answer, well, that's the way to go. I would never get it because I'm not going to risk it. On the other hand, people sometimes answer, my OB didn't even bring it up. Probably the best thing he could have done for me. And others say, yeah, great, who's your OB? And Other people say, actually, I did use it. I am 25 weeks pregnant. I'm fully vaccinated, and we are great. Both me and my baby are doing great. I'm so happy that I used it. Now I'm protected. And a lot of people, you see the face of the laughing. Some people say, no, you don't know. Maybe your baby is not going to be okay in 10 years from now. So it's very interesting to read the comments from the people after you post your advertisement, and often what they say can help you change some questions, can help you understand the answers to some questions, and that's why it's so important. Like in business, it's important to know your customer. In the business of pregnancy registries, it's important to know the pregnant population even before you conduct your study. Now, a very important aspect, often disregarded in people that don't have much experience doing pregnancy registries and studies in general, is the issue of data quality and data system validation. It's very important that if the data are going to be used by, for example, pharmaceutical companies to fulfill regulatory requirements with some agency, that the data need to be very valid, and that the systems need to be valid. That means that every single system, data collection system, data management system, data analysis system, data communication system, need to be validated. It's part of an entire field. I could spend hours talking about the data validation systems that we have in place, but for you to check, and by the way, you can download this presentation, so you don't have to remember things, you don't have to write things, because you can download later on this presentation. FDA 21 CFR Part 11 is a very important aspect of data validation. Every piece of information that the study participant provides to you needs to be logged. It has to have a log trail in such a way that if you get inspected or if you get audited, you can show that the data that you have on the screen is truly the data that the study participant provided to you, and that there's no data tampering, there's no data manipulation. This is truly the data from the study participant. So very important to do this kind of validation of the systems. Also, because we are dealing with an online study, of course, we cannot see the other person. So we need to verify that these are, first of all, humans and not bots. They are not robots or machines. And second, hopefully, that they are truthful people. So one step is to ask for a phone number verification. You have to submit a cell phone number from wherever you are in the world, and you are going to get a one-time password, an OTP, and then you type the password and your phone number has been verified. Once the phone number has been verified, you can move on to the next step for the registration. And that's a very important step, because in this type of studies, when you don't do this, you get a lot of pranksters, scammers, and bots answering your questions, so you don't want to do that. You don't want to get that. Also, we ask the participants as much as possible to upload redacted medical records. In some aspects, in some cases, this is a mandatory requirement. In other aspects, in other circumstances, it's a voluntary. We ask them to do it, but they don't have to do it. And they have to redact the document. In other words, they have to cover the name and the phone number or the address that they have on the medical record. If they don't do it, we have a system, a validated system that online can redact. In other words, can make the information black so that you cannot see what's behind. And in that way, the medical records are redacted and uploaded. And that gives another reassurance to the researcher that this person is probably a real person, is probably a pregnant person, because the person is going through a lot of trouble to answer the questions, to upload records. And as you will see, we don't provide any incentives. Why would they do it if they are not going to get anything in exchange? Now, we also have to think about people who are pregnant. Sometimes they have other children, they are very busy, sometimes they are in pain, and they make mistakes. They make mistakes because they are busy or because they don't understand the question. So you have to try to minimize the likelihood that mistakes will be made. How do you do it? For example, if you have calendars, if you are asking them, when did you get the vaccine? You cannot get the vaccine before a certain time. When did you get the adverse event? It had to have happened after the vaccination. We provide ranges within our system in such a way that impossible answers are minimized. Finally, we say that there should not be any kind of incentives to enroll study participants in a study, because that's when you get all the scammers and the liars and the pranksters and the incentive professionals. They will come to your study, they will create 1,000 Gmail accounts, they will pretend that they are eligible study participants, they will get your incentive, you will go bankrupt, and your data will be equal to nothing. So do not offer incentives at the onset of a study. Now, if people are participating in your study, and then in the middle of the study or more at the end of the study, you say, well, in order to compensate you for having been in our study for the last few months, we will give you a little present or something, some monetary or some gift card a reward, then that's perfectly okay, because these are people who have been participating in your study, legitimate participants. But never do it at the very, very beginning, because you will get a lot of people who will be just making up accounts to get your money. Finally, trust index. This is a concept that we are developing, and we have been working on this concept for some time, where different individuals, depending on the amount of information and the quality of the information, get assigned a trust index. So if you, for example, upload medical records, if you answer the questions, if you provide feedback in the feedback section, you get a trust index that is high. If you are a person that doesn't answer almost any questions and doesn't provide us with any medical records or anything, you do not answer any questions that we query you to answer, then your trust index go low. And then when you have everybody classified with a trust index, you can do a stratification. You can decide, I will only analyze the people with a high trust index, or I will analyze everybody. I may do some propensity scores. I may want to do some adjustments. That's up to you. But the concept of the trust index is important to exclude, especially those fake participants, since you cannot see them, and the regulatory environment doesn't allow us to get copies of a passport or a government ID. You are not allowed in many countries to ask for that kind of verification. Plus, actually, even those documents could be forged online. So what technologies do we use to collect the data? We use a variety of technologies, very, very sophisticated technologies that are making our pregnancy registries personalized. We use an online data collection based on machine learning, as you will see. We use also auto-populated fields in such a way that if a study participant starts writing the name of a medication, it gets auto-populated no matter in what language and in what country, because we are using a drug dictionary. If the participant starts writing an adverse event, that also can get, it gets auto-populated if it's part of our MedDRA dictionary. So we facilitate the completion of the terms and the medications in that way. We also do real-time coding of the medications and the adverse events, as I said, because we use the WHO drug dictionary, we use MedDRA, and in that way we can immediately know, if you are familiar with MedDRA, we know the preferred terms, we know the LLTs, we know the SOCs, and if you are using the WHO drug dictionary, you know the different levels of the drugs, it gets automatically coded. In that way, you can do line listings, you can do reports. So it's very important that when you are doing data collection, you offer this technology to the study participant to avoid typos, to avoid confusion. Of course, there could be always the confusion, hypothyroidism and hyperthyroidism. Not every study participant knows the difference between hypo and hyper, and there may be mistakes. However, you help them a lot if you are auto-populating the text. We also use an electronic gateway to transfer the adverse event data to pharmaceutical sponsors, because in that way you avoid, or minimize at least, you avoid to a certain extent data entry errors. So all the adverse event data that you are collecting, that you are processing in your safety database that we have an Argus safety database, it gets transmitted electronically to the sponsors through an E2B gateway. Also from our clinical database to the safety database, it gets transmitted through a gateway. So from the moment that the study participant enters an adverse event until the pharmaceutical sponsor gets that adverse event, theoretically could be literally 1 second. It comes to us and goes automatically to the pharmaceutical sponsor. Obviously, we want to process those adverse events. We want to do all our assessments of seriousness, expectedness, relatedness, and therefore we need, and we write a narrative if it's a serious adverse event. So we need to get all those adverse events, but they come to us from the clinical database through a gateway. There's no manual data entry. And I highly encourage you to think about doing that. It's not simple and it's not cheap, but I highly encourage you to do that, because the amount of data entry errors when it's done manually is very high. And finally, technologies like the ones I'm describing allow you to use wearables and sensors. You might be interested in high blood pressure in a part of your population that has high blood pressure, and you want to then provide them with sensors, or you want to provide them with a blood pressure monitor, or you want to have simply a smartwatch that can collect some information, maybe amount of walking, amount of exercise. Depends on what your study is doing. So if you're doing an online study like ours, if you're doing a study that is collecting the information already electronically, it's relatively simple to integrate the wearable information to this prospectively data collected from the mother. So I want to show you an example of what I mean with the machine learning and how it personalizes the data. On the top, you will see a video. This is for you if you're going to download the presentation and want to see it in your place, and you don't want to create an account as I will show you on the website, you can just watch the video. It's going to be the same thing that I will show you now. So I will show you now in a second how we personalize. This is a very short example, okay? And this is a real-time example. I'm not using anything recorded here. So let's suppose that here we asked our study participant about your COVID vaccination history, and we asked the participant what was the name of the manufacturer of the COVID vaccine that she received. So of course there's a variety of vaccines depending on the region. Some of them are approved, some of them are authorized, and some of them are not in some countries. But let's suppose that we choose Pfizer, okay? And we say that I use Pfizer. Okay, perfect. So below, the system already knows, because it's Pfizer, there could be 2 doses. Yeah, now there could be 3, but in some countries especially. But let's imagine 2 weeks ago, there could be 2 doses. So could be that you received 1 or 2 doses. Let's suppose that you say you received 2 doses. Now, it is possible that you received 1 dose before pregnancy and the second during pregnancy, or that you received both doses during pregnancy. So the question is, how many did you receive during pregnancy? Well, let's suppose I received only 1 during pregnancy because the other one I received it before I got pregnant. Okay, so then the question is about the first dose. Here, the calendar is related to information I already provided to the system about my last menstrual period. So also, you will see that it's impossible that the vaccine was available before November, simply because it was impossible to get the vaccine, except for clinical trials, before November 2020 anywhere in the world. So you have to choose when you receive the vaccine. Let's suppose that you received the vaccine on the 31st of December of 2020, and when you do this on your phone, it's all optimized, looks perfect. Then you can upload your COVID vaccine certificate. This is a very important part. I'm not going to do it at this moment. And then, for example, it asks did you experience any adverse reactions within 48 hours after the first dose of the COVID vaccine? The system already knows what vaccine you received. The system knows when you received the vaccine. The system knows where you live. And so if you say yes, now it will ask you what type of reactions. Let's suppose that you say, these are the most common, that we offer them proactively. Let's suppose you say you had fever. It will ask you Fahrenheit or Celsius or unknown. Let's suppose you say Celsius. Let's suppose that you say you had something like this. The system already tells you that's not possible. You cannot have like that. It needs to be within a range. So, okay, you enter 38 degrees, perfect. Now the start date cannot be before the day of the vaccination, because it said within 48 hours after you got vaccinated. So as you can see, if you want to say that you had this adverse event before the vaccine, it's not going to allow you. It's not going to allow you to have it before November, before December. See, it can happen only after December. So, and then if it will ask you how did you measure the fever, and then the outcome of the event. If you say recovered, it will ask you when the event finished. If you say that you still have it, it will not ask you because you still have it, etc. So the bottom line is that the system gets adapted to the way you are answering the questions, and the subsequent forms and questionnaires know how you answer the previous questions. So it will keep asking you related to the way you answered before. It knows where you live, it knows your demographics, it knows your medical history, it knows your reproductive history, it knows your COVID vaccination history. So any subsequent questionnaire, it already knows about you. It will ask you, are you having twins? If you say yes, from that moment on, it will ask you about baby one, baby two. So in that way, you personalize your questionnaires. It's not like written on paper. It's personalized according to your characteristics. So going back to the presentation. Now, adverse events, the collection and reporting of adverse events is a very important component of a pregnancy registry, because the way we do pregnancy registries nowadays in 2021 is a combination of a pharmacoepidemiological study and the pharmacovigilance activity. So we have to conduct the collection and reporting of adverse events in the same way or at the same level that if we were in a pharmaceutical company. We develop a safety management plan. We have the data managed and processed by drug safety professionals. We use a proper validated drug safety database. We use the gateway that I was talking about before. We do the assessments that I mentioned before. And then we do signal detection activities and signal management activities according to the guidelines, particularly the good pharmacovigilance practices that indicate that first, if you have a safety management team, you identify a potential signal, you do a validation within the safety management team and maybe with some colleagues. If the signal is validated, then it goes to a second stage where our scientific advisory committee discusses the characteristics of this signal. And if they agree that this signal is accepted and that this is a risk that we didn't know about before, then there will be an action. If the signal is not validated, it's basically a non-validated signal. It's put away. If the scientific advisory committee does not accept this as a true new signal, it's a refuted signal. So we follow these good pharmacovigilance practices like many of you are doing in your work on a daily basis, or your colleagues are doing in your companies. And in that way, we come up with validated signals that we share with the regulators or we share with the sponsors. And we do it in the exact same way or even a higher level than many pharmaceutical companies, with a safety management team composed of drug safety professionals, and you should do it too. This is not the time anymore to do studies in which the collection of adverse events is the problem of the pharmaceutical company. Call the pharmaceutical company, call the FDA. No, it is your problem. If you're conducting the study, it is your problem. And if you're conducting the study sponsored by a pharmaceutical company, it is your problem. You have to collect it, you have to assess it, you have to do your signal detection activities. So this is a very important aspect, and I know, Andrea, we are getting to the end of the presentation. Engagement. It's very important to have your study participants engaged. Otherwise, you will collect 18,000 participants or 100 million study participants, but only one will give birth, and only one will tell you that they gave birth, and all the others didn't tell you. So then it's useless, basically, how many people you collected, because you don't have any outcome information. So you need to really work very closely with the study participants online, using text messaging. In some places, they use WhatsApp messages, phone calls, to get these study participants to participate, to provide you with information throughout the entire pregnancy and the 12 months after the baby is born. We call it a concierge system. When you go to a hotel and you find the concierge asks you, do you need recommendations for a place for dinner? Or do you need recommendations for a place to take the kids or to go and visit? When you join a pregnancy registry in 2021, you need to have a concierge. You need to have someone who will welcome the study participant and say, is there any question that you have? Can I help you with something? It's not the time anymore of, you have to answer the question because I'm the doctor. And I'm going to help you, many people with public health. No, that's not enough. You have to produce this feeling that you are giving and you are receiving. It's a community. It's no longer a study, it's a community. We use text messages, intranet, direct messages, phone calls, newsletters that are personalized, because we know so much information about the study participant that the newsletter can be targeted to the study participant. No more of those newsletters, one newsletter for everybody, because those are boring and no one will read it. Everybody will delete them. But if it's targeted to you, we know your vaccine, we know your country, we know a lot about you. We can make a newsletter that is for you. So here, for example, you see a direct message within our intranet system with a study participant, where we are asking the study participant some questions. We are telling the participant that we want to know different things, and I'm finishing with this one. I want to show you something before we stop, Andrea, about participant engagement. Again, this is a video, so you can do it from home, but I will show you in real time. This is a technology that we are developing. It's based on a Microsoft technology called Microsoft Power BI. Here you see, this is not real data. We are practicing with this. Let's suppose that your study has 7,484 study participants. With this technology, you click there and you show like a line listing. And then you can do your own filtering by manufacturer, by time, by country. And then let's suppose that I'm interested in only looking at the Moderna vaccines. I click on that one, and automatically everything now changes to the Moderna vaccine. I want to know the Pfizer, I click there, and now everything changes to the Pfizer vaccine. This is the technology that allows you to see real-time data because it's connected to your either analytical database or to your raw data. So in this way, you can do all these selections, see how you can do different things real time, and you can do it by country if you go to the map, or you can look at a certain point in time, and everything changes according to that specification, and then you can see it as a table. And this technology is available to you. It's not, I'm not showing you anything that is developed by us, actually. This is a technology that you can think about. Is again, is the Microsoft Power BI. You can search online, and then you can show in your post-marketing study in the same way that sometimes in clinical trials we use Spotfire and some other, all of you from IQVIA, you have your own system. We use this system for a post-marketing study. So this is pretty amazing. And with this, I'm finishing. I know that this is the end of the time, but the master file is something that you should look at, everybody should look at, because it's the way to get organized. It's the same as in a clinical trial, the trial master file, but in the post-marketing setting, in the observational study setting. And we provide you here the core artifacts of a study master file, but there are recommended and not required artifacts that you can think of. These are documents you need to have available in a folder or in a system called the study master file. So I'm going to finish this presentation by saying the things that work and the things that don't work. Things that work is the combination of a simultaneous pharmacoepi study and a pharmacovigilance activity, online technologies, information obtained directly from the mother, follow-up is done monthly until end of pregnancy and during 12 months. And you need to use a system that personalizes the data collection. Otherwise, people will be disengaged and they will think, why are they asking me this question? If you want increased engagement, the data collection system needs to be personalized. You need to query, you need to contact, you need to have a concierge system if you want the study participants to stay with you for on average 15 months. And you need to have a true drug safety team, safety management team to process all those adverse events. And finally, if you want to be compliant, as you should, you need to have a study master file. This is all. I will be happy to answer any questions, and you can feel free to also download this presentation and to email me any questions as well. Thank you.
Thank you very much, Diego. This was an interesting presentation and very different from the previous ones. Let's go, I would say, directly to the general Q&A. And if anyone has any question, I don't know whether we can unmute people or otherwise if people prefer to type.
If people want to go ahead and speak, they can just raise their hand and I will unmute them here. Otherwise, you can answer your questions in the chat box and we'll be happy to read them out and get them answered.
Hi, folks. This is Judy. I'm one of the co-hosts, so I unmuted myself to ask this question. I just have a question for Diego, if you wouldn't mind following up. So if I understood correctly, and I apologize, I might have missed it, you are asking the pregnant people to upload their records, periodically over the course. Have you guys considered thinking about asking them for their consent to link to the actual medical record themselves to alleviate their need to keep uploading information over time to make it easier for them? And just asking if you'd comment on that.
Yeah, that's a great question, but the answer will become obvious when I make the point that we're a very international study. And that makes it extremely difficult to link the information that the mother provides. And the mother is, remember, the mother is like the music director. She has all the records of her entire pregnancy history and the child's first year of age. If we had to go through the specialists, we have OBGYN, COVID, pediatrician, neonatologist, infectious disease, the one because the baby has a runny nose, then the mother had chest pain, so she ended up in the cardiologist. We will have so many specialists with so many ethics committees or IRBs to go through. In an international setting, it would be impossible to do. So practically speaking, the most operational way to get the medical records is through the mother. Sometimes you cannot get them, and we understand that. Sometimes you cannot get them. But when you are doing a study that is literally in 70 different countries, some of them with very poor health systems, they still have a phone to answer the questionnaires, but the system is very poor. You know that the likelihood of linking with any medical records is going to be pretty close to zero.
Thanks, Diego.
Sarah has her hand raised. Sarah, do you have a question?
Yeah, hi. Sounds like a tremendous amount of work. I'm just sort of curious, how large is the study team on this? And I'm also curious, when you do something like this, do you have like Facebook or Google collaborators? And then my third question is, or do they just sort of give you the data? And then my third question is, and I don't know if this is a sensitive question or not, but I was just curious about the funding source. It just seems like such an enormous undertaking. I'm just curious who is sponsoring the work.
And it is sensitive, but it's not confidential because I disclosed it on slide 2, and I will repeat it. But good questions. The first one is the team to do a study of 18,000 participants collected within 6 months, or 8,000 participants collected in 10 days is large. But it's not large when you think about a large company like IQVIA, where Andrea comes from, or RTI. There are other IQVIA people here. Sorry. I will promote everybody. There's PPD, Cognizant, IQVIA. Full disclosure. We are only about 25 people working on these 2 pregnancy registries. Of course, the more we enroll, the more the larger the group will need to get. So, for example, at the moment, our safety management team has 6 people, and we have 8,000 participants in that study. But we prioritize the amount of work, and not everything gets analyzed at the same time. We do have to follow the very strict adverse event reporting timelines with the pharmaceutical companies. So our first priority are the companies that are sponsoring us. This answers your third question, actually. Where do we get the money? So our IRCEP study is sponsored by Johnson & Johnson and Regeneron. Our COVID vaccine study is sponsored by AstraZeneca, Johnson & Johnson, and Novavax. And our COVID PR study, our therapeutic study, is sponsored by GSK and by, we just got the contract. We have many contracts in negotiations, but GSK and Gilead for remdesivir. So there's a significant amount of savings when you are doing a study online, actually. And when you are doing a study that can share a lot of the technologies between one study and the other study, between one population and the other population. Yes, you need people who will translate. If you are doing the study in Pakistan, it needs to be in Urdu. And if you are doing the study in Israel, it may need to be in Hebrew. And if you are doing, which is right to left, written right to left, and that messes up your graphic design. So you need a graphic designer to take care of that. Yes, there are some small details that need to be taken into account that are specific. But in general, you can do economy of scale. These studies are quite inexpensive, actually, compared to the way we used to do these studies in the 1990s. Very inexpensive. With a team of 20 people or so, 20, 25 people, you can do a study of 18,000 participants without any problem. Actually, we will have 50,000 participants, and in the vaccine study, we'll have 20,000 participants, maybe. The therapeutic will have about 10,000 participants, and we can collect them in a matter of 5-6 months, and then we have to follow them up during pregnancy and then during the 1 year of the baby. That's the work, the concierge. That communication is individual communication. We don't send any shotgun, messages to everybody. Thank you for joining. No, we send one by one, written by a human in the language of the person who enrolled. A welcoming language, a welcoming message. Yeah, it takes time. People work, people love it. It's a good cause, and people work hard and they love it.
Wow, that's really impressive. Are there 25 people? Sorry, and then that's my last question. Are there 25 people from different countries, or are they mostly based?
Yeah, I'm sitting in the UK, for example, like Rohini over there. I can see you, Rohini. Hi. I'm in London, but most of the team is, we have 3 people in Serbia, we have 1 person in Portugal, people in the US, we have people in India, we have people in Africa, we have 1 colleague in Kenya, we have in different countries, yes.
It's amazing.
It seems that Judy has a question, and it's actually quite similar to a question that I had. So Judy, do you want to go ahead?
Sure, Andrea. So just a question for all of our panelists who all presented studies on particular methodologies and techniques during the COVID-19 period. So the COVID-19 pandemic looks like it's breaking into little mini pandemics within itself. And so certainly in the United States right now, entering a period of high vaccination in some areas, low vaccination in other areas, Delta as being the primary variant. And I'm sure that in other countries, there's similar but not exactly the same patterns of how your methods might have to be adjusted to account for these sort of different temporal sequences within the pandemic period itself. So this is for all the panelists.
David, can you hear me? Oops. You can hear me. What is?
Yes.
How pleasant. Again, I'm sorry for the connectivity issues. I'll answer first because I was so poorly connected before, and who knows how long it's going to last. You know, it's an interesting question. I was thinking about a similar question, Judy, as Sarah was presenting. Like, how would you tailor just your cohort identification methods if what you wanted to identify was patients with long COVID or patients with a much higher probability of having long COVID, despite all of the unknowns about how it's defined? And it'd be, first of all, it might be more challenging in something like long COVID if there aren't many cases to use for a data-driven approach, at least. So that was one thought. More specifically to your question about sub-pandemics, you know, maybe in the 30 to 40-year-olds, higher and lower vaccinated areas. I think for the cohort identification piece could be similar. Other aspects of the design would have to focus on this, you know, you'd have to incorporate in that three-dimensional cube I was using to talk about severity, certainty, and other dimensions. You'd have to add a dimension there or two to capture some of the other aspects of that subpopulation. That's my initial thought anyway.
I would also add that I think just as important as that is, I'm starting to see with some of my research, we're doing systematic sequencing. Obviously variant type. I mean, I was thinking mentioning that we don't even know if things like, you know, we know that potentially VE differs, vaccine effectiveness, and potentially long COVID, and people are looking at symptoms. I mean, you also have sort of sub situations within the different variant types as well. And because the variant types also are changing over time, it makes those type, you know, just overall sort of cumulative analyses even more complicated, and you know, the need for adjust for secular confounding even more important.
I would say for the studies that we've been doing, looking at ethnicity, what is becoming more and more relevant now is using the data we have, findings from real world data, but also cohort studies and census studies to refine our question. So instead of using ethnicity as like the one proxy for risk of infection outcomes, it's teasing out what increases, you know, are ethnic differences related to increased risk of exposure or poorer prognosis once infected. And so I think what the data from the UK are showing is that ethnic differences are more related to higher risk of exposure. So now we're tailoring our study questions to look at how do ethnic differences in household structure and occupation affect the risk of COVID-19 susceptibility and outcome. So we're sort of building very incrementally on the question to tease out the kind of upstream effects, the upstream things that affect ethnic differences.
That's a very good point, I think. If I could add to that, one thing, you know, in the Sentinel Common Data Model, which is an enormous and very powerful resource, but by design, there's a lag in that data because it's QC'd and it's very carefully curated. To look at some of these sub-pandemic issues, we have to go to current data. And so I think that's going to introduce some challenges that require some nimble approaches, so that maybe we program against electronic health record at different sites. And then the other, just one other thought would be, natural language processing for fairly simple natural language processing could be used to help identify some of these sub-cohorts. Maybe there's mentions about variants, even if you don't have the PCR data, if there's suspected variants involved or other features of the group that you want to look at.
Thank you. Christopher, I wanted to say that feel free to participate if you have anything to add.
Hi, thank you, Andrea. Yeah, no, I'm here. Nothing to add on the race ethnicity stuff in the US. It might not surprise you that, being at the same institution as Rohini and working closely with her on the UK stuff, having access to the similar US data, we kind of align our research strategies to make sure we're, broadly looking at similar things. And unfortunately, within the Veterans Healthcare Administration in the US, we have very good data, as my previous comment suggested, but we do not have demographic data related to occupation or household status. So there are some very excellent groups around the country in the US that are trying to now link in more nationally representative data in order to bring those variables in. But again, with data privacy concerns, matching at an individual level is often not possible. So we try to match at the census tract level or county level in order to do some proxy, and nothing interesting coming out of that yet. I know there was some individuals at Stanford who tried to bring in some external data on social determinants of health and tried to, in a way, see if that was contributing to the excess risk in testing positive, particularly among Black and Hispanic veterans. And once you've accounted for all of the 20 different demographic and clinical characteristics that we have available in the data, adding in that social determinants of health didn't do much in terms of the estimates. And it's hard to say whether truly social determinants of health aren't impacting anything beyond the clinical and demographic covariates, or is it that matching at a census level, county level, kind of muddies the information there and just kind of washes out in the model. But the VA is trying to roll out income data on all of its patients. TBD on what the quality is of those data, but we'll follow up.
Interesting. Thank you. Any other question?
This is David again. I would just mention on the point, Christopher's point about adding other data sources, and it is at the very least, it's a sensitive issue, even though some of the technical barriers to linkage may be resolvable. There's some folks here at Kaiser Washington who are looking at linking credit and civil legal proceeding data for the purpose of enhancing suicide risk prediction models. And it looks like it can be done. What's not certain by any stretch is how acceptable that kind of linkage would be.
Acceptable
yeah.
To whom?
I'm sorry?
Acceptable to whom?
Well, acceptable to the patients who's, we as secondary use of data, we generally get IRB waivers of consent to use their data. And in studying COVID or suicide risk prediction, that's that generally is necessary and feasible. But how patients would feel about their healthcare provider linking their medical records to credit data that might tell something about their economic status, or civil court data about divorces or involvement in the criminal justice system, could be quite a different, it's a hot button issue, I'm sure, for a lot of people. And so to sort of complete the story, the folks that I'm speaking of here are starting to survey patients about this very question, see what kind of reactions they get from the patients on that kind of stuff.
Do we have additional questions from the audience? Okay, let's see. Would you like to read out to ask your question yourself?
Sure, can you hear me?
Yeah.
Yeah, so I was just, because I mean, this is a little bit tangential to the discussion that was happening, but, there is the, data, that coming out of the US and the UK suggests that life expectancy, especially in certain ethnic groups, has dropped, in the year that was COVID, or, and continuing. And just to understand the impact of that, COVID exposed, COVID unexposed, and looking at, the by how many years, I mean, you could always look at historical controls, but, looking at live patients that are essentially, same year, everything is the same except for that COVID exposure. And like New Zealand is an example because they were like completely locked off and still are. So I don't know, I mean, I don't even know if this question makes sense, but I was just wondering if that would be something that would be, possible to explore using some of the methods that have been discussed today.
Are you asking any one of the panelists?
No, anybody can respond.
It's an interesting question. So in that case, would the unit of analysis be the country? And if so, I'm assuming we'd have a pretty small n study, but still, potentially useful.
Yeah, probably something like an ecological type of design.
Yeah. I think there's been some research that use those kind of designs to look at diet, associations between, say, diet and cancer, or diet and other health outcomes. So I don't do it. I'm not, aware of all the pitfalls or opportunities, but it sounds like it could be an interesting thing to look at.
Thank you. Eleonora also has a question. Eleonora, would you like to speak up?
Do you see the question from Eleonora in the chat?
Yes, I'm trying to unmute her though. Okay, I can't unmute her, so I will read it myself. Okay, her microphone is not working well. Eleonora's question is for Diego. The question is, how likely is it to miss severe safety events when it's only the patients who are providing data?
It's likely, but actually it's more likely that they will not report the ones that are not severe, because they think it's part of the range of normal. Actually, when a mother finds that she has something serious, or her child has something serious, she doesn't keep it quiet. She makes it very clear that there's something happening. On the other hand, if there's a little bit of concern about something, if it's very non-serious, there might be underreporting. I don't think that for serious adverse events, or severe adverse events there is underreporting, but it can always happen, like it could happen even in the context of a clinical trial. In any context, it can happen. But I have to say that mothers, and all of you who are mothers know, that are very hypersensitive, so to say, to events that are happening during pregnancy and to their babies. And very hypervigilant, more than hypersensitive to those events, and they are going to report it, especially because we are asking them to report things as they happen. We don't contact them 6 months later, like in some old style pregnancy registries. They have to call maybe a couple of times during the pregnancy, like separated by 3 months, and they might not remember. In our case, because it's online and we are constantly in touch with them, as soon as it happens, they report it. And we can query them, we can start a discussion about it. So the likelihood of underreporting is much smaller when there's this kind of close relationship.
Diego, quick question. Do you use only email, or are you guys using text features like text phone as well?
So we did an experiment of using email, and it turns out that a lot of the young generation, they don't even check email.
Right.
The ones that use it for work maybe, but and for school sometimes, but the current generation of young people, let's say in their 20s or so, they are much more into texting. So basically what we do is, first of all, we have their phone numbers so we can send them text messages, no matter where they are in the world. Second, the system to do the data collection has that internal direct message system, which is encrypted and very secure. So we can do the two-way conversations with the study participant in real time. It's beautiful to see it. You know, someone could be in the other corner of the world, and you ask her a question and you receive the answer immediately within the data collection system, not using WhatsApp or using text message, within the data collection system. And if you need, you have to do it in that language, but that's a detail. And we do send emails occasionally, but we also call them. We use a validated phone call system within the system. Within the data collection system, we have a calling system that records all the calls because of the validation aspect that I mentioned before. Every phone call is recorded and it's done within the system. It's not like me using my phone or, no, it's within the data collection system, uses voice over internet. We can call anybody anywhere in the world. They can call us too. And so we have different methods. Some people use text message, some people use the direct message, some people use phone calls, some people use email, some people will try everything because one thing doesn't work. So we have to keep trying until we give up. And so we try everything. The only thing that we haven't tried at the moment, but we are practicing, is how we can use WhatsApp in a validated system without infringing any data protection laws. Because that's free. Everybody pretty much all over the world seems to be using WhatsApp, or almost everybody. Probably someone here will say, I don't use it. And but almost everybody uses it. And it's a good system. You can upload photos, you can upload media. So we are trying to see if we can use WhatsApp within our study, but that there are some GDPR issues that to take into account, and we are very strict with GDPR. And so at the moment, we are not using WhatsApp, but we are using many other systems.
Yeah, that's great.
Any other question? Okay, if there are no other questions, I want to thank very much our speakers and panelists and our registrants and attendees, especially to the ones who are still around. And thanks to Shannon for supporting this. And we'll close the session.
Thank you, everyone. Have a great day.
Thank you.
Thank